Hi everyone, Assalamu alaikum. My name is Momo Arai and I'm an intern. And I'm really excited to give you guys the renal pathology crash course today. Inshallah, we'll try to cover all the high yield concepts and there will be questions at the end and summary tables throughout the lecture. So let's get into it. So first, I would like to start with the anatomy, the renal anatomy, of course. Just don't forget the normal, so that you can differentiate it from the abnormal diseases that we'll take. So of course, you'll have the cortex of the kidney, the medulla, and the pelvis. Those are like the main things that I want you to focus on. And so cortex is the outer layer, medulla the middle, and the pelvis. And then it will continue as the ureter down to the bladder. The other important thing is the arterial or the blood flow of the kidney. So you'll have the blood coming in through the renal artery, then dividing and branching into smaller branches called segmental artery, and then segmental artery, then interlobar artery, so between the lobes of each kidney, and arcuate artery is the one that's kind of like making an arc. Um, and interlobular artery between the lobules after the arcuate artery. So after this, there it will be interlobular artery. And then it will supply something called the glomerulus. Now, glomerulus is like the functioning unit of the kidney. It's where the whole filtration takes place in the cortex. And that's where this is present. So this is the same thing, interlobular artery going into the glomerulus as afferent arteriole and then coming out as efferent arteriole to supply the rest of the tubules. So we call this part glomerular capillaries, and then the tubule part peritubular capillaries, okay? And then it will go on to be the renal vein, and then it will drain the exact same way, but in the opposite direction. So it's very important to know that, and very important to know as well the glomerular part here, and the tubular part here, because there will be diseases in both of these parts. Um, and yeah, that's mainly it. So the filtration will happen here, and then it will go on to the medulla, and then until it becomes the urine in the bladder from here, from the pelvis. Okay. And these arrows that you see here are filtration. Some things will be reabsorbed because that's the function of the kidney. Some will be secreted into the kidney and then excreted all the way. So this is to the bladder. Okay. Now the first part of this, or the first lectures that you guys took were about glomerular diseases. So the glomerulus, again, is the structure that helps with the filtration, or sometimes we call it ultrafiltration. What's the point of filtration is to filter out, um, so the substances in the blood has to be filtered out. Uh, what will not pass into the urine are two things. So proteins, mainly proteins, albumin, and cells. So red blood cells, these are supposedly, like, it's not supposed to be in the urine. And this structure, the glomerulus, helps it to be filtered, helps the blood to be filtered. And they will go along the capillaries, while the rest, so like waste substances, all of these things will continue into the urine, or be filtered. It will be filtered into the space called the Bowman's capsule. So this is the normal histology of the glomerulus. You'll see numerous capillaries. These cells here are called mesangial cells. Um, Basically the functioning cells of the glomerulus, and surrounded by capillaries. And this white space is the Bowman's capsule. It's where the first filtrate, or the urine, comes, or is filtered here, and then it will go on to the rest of the structures, which we will see. Now just remember that the normal part. Now this is again the normal glomerulus in a very, very, if you zoomed in, per se, like here. So if you zoomed into this part, you would see all of these structures. Now, what are these structures? These structures are essentially making up the barrier, or the filtration barrier, in the glomerulus. Why is this important? Again, to keep the proteins, RBCs, in the blood and not to lose them in the urine. If we were losing them in the urine, it would be a problem because you don't want to be losing proteins, all right, from here. Now so this is the filtration barrier. It's made up of three main things that is important. So you would have so the side of the capillary here, that's one there. Then there is the basement membrane of that capillary, and then the epithelium of this after the Bowman's capsule. So it's part of the urinary system, but that part is known as the sometimes visceral epithelium or podocyte. So let's go in order again. So first it starts with the capillary, right? So that's where the endothelium. So it can be called endothelium, endothelial cells. The important thing is that this is where the blood comes like first into contact, and then it's filtered through here, the urine. So these are fenestrated, which means that it has it forms a tight barrier, but it also has space for or pores for the rest of the urine, the waste substances to go through. Then you have the basement membrane here, all of these are the same thing here and here, which is again, it's also negatively charged and it forms that strong barrier. Then you would have the visceral epithelium, and these cells on that side are something we call podocytes, and so this is one podocyte, for example. It's essentially a cell on this side of the barrier. It has these, you can see these are processes. They kind of look like foot sticking out. So these are podocyte foot processes. And the important thing for this is, again, the barrier. And it's creating like space for the urine to flow through. Now, what other structure holds this barrier together is the proteins that are present in this and these food processes. So these are things like nephrin, podosin, actin is an important one if they ask. So these are important proteins, negatively charged, basement membrane, fenestrated endothelium. This forms the filtration barrier. And you can see that these are the electromagnetic pictures of all of them, okay? So these are the normal. Now, glomerular diseases is anything that, so if there is an injury to any of these sites, that's when you have a glomerular disease. There's a lot of different types, and you can classify them broadly to two main syndromes. So we call the first one is nephritic syndrome, and then the second one is nephrotic syndrome. So this spectrum, how can we classify something being nephritic and nephrotic? Is based on the site of injury. So for nephritic syndrome, from the name, nephritic means inflammation of the endothelial cells mainly, and I'll come to that slide in a bit. So that's where the injury is. So you'll see it here, nephritic syndrome. Nephrotic syndrome, on the other hand, is a damage to the podocytes that we saw before. Okay, so that is the difference, the site of injury and the symptoms that they present with. So nephritic syndrome presents with this. So if they give you a scenario of someone coming with having protein in the urine, let's not say the amount yet. So protein in the urine with hypertension, and also they see spots of blood in the urine. This is most likely nephritic syndrome. So the protein amount would be less than 3.5 gram over 24 hours. Again, there could be high blood pressure and hematuria, meaning red blood cells being in the urine. So because of this damage to the filtration barrier, remember how I said they are used to keep them out? These blood and protein will pass through the damaged filtration barrier. You would also have sometimes WBCs in the urine, and there would be a kidney function impairment, more so than the nephrotic. So there would be things like oliguria, which is less amount of urine, and azotemia as well, which is absence of urine production. Now, nephritic syndrome here, you can see a simple diagram. It's mostly red blood cells with a few less than 3.5 gram of protein. Nephrotic syndrome, on the other hand, has massive proteinuria. So you see more of it here, more than 3.5 gram or more. In urine dipstick, which is another test that we do in the urine, it would show a very large grade of protein. So 3 plus, 4 plus means a large amount of protein in the urine is present. Now, if someone is having massive proteinuria, they would be losing a lot of proteins, more than nephritic. Their bodies would be in a state of hypoalbuminemia. So that means because they're losing proteins, the reason why is because most of our proteins that are lost here are albumin. And that makes the body like devoid of albumin, and that's why the body goes into this state. Now, if you have less protein, if someone has less protein in their bodies, they would have something called third spacing. So if I try to explain this, it will go back to the foundation, like the basics of fluid, like interstitial fluid. So if protein is lost, you lose something called the oncotic pressure, right, from the capillaries. Now, if you lose the protein pressure, that oncotic pressure was used to hold the liquid inside the vessels. Now that the proteins are lost and the body is in a state of hypoalbuminemia, then it's harder for the vessels to keep hold of the fluid and the blood. So there will be loss of fluid into the interstitial space. Loss as in it will cause accumulation outside of that capillary, causing generalized edema. So you would see people like in the question stem, for example, they would be coming with edema all over their body, in their eyes, in their legs, sometimes all over, even their hands and feet as well. So that would give you an idea of nephrotic syndrome. All of this loss of protein, again, is a very major factor. It's the most important differentiating factor from this and from nephritic syndrome. So why is that? Because it causes another thing for nephrotic syndrome, which is hyperlipidemia. So because protein is being lost, right, the liver starts to like overproduce protein and overproduce things to make up for this loss, including lipids, or fats, which can also be lost in the urine as fatty casts or fat in the urine. Okay, so that's lipiduria or fatty casts. Casts, I will come to explain this in a bit, are abnormal structures, accumulation of fats in the urine. Now, why is this important? That's because hyperlipidemia is very, very bad for cardiovascular system. So if you have a lot of fats accumulating, you know that it increases the risk of atherosclerosis and then heart attack, stroke, things like that. So that is very important. Again, if they ask you what is the one like main cause of mortality in people with nephrotic syndrome, it's actually cardiovascular diseases, because of the hyperlipidemia. And then, of course, kidney damage is another reason. So be mindful of that. And yeah, those are mainly it. So I mentioned this part, nephritic. So the hematuria, the blood in the urine, can be RBCs that are deformed or as casts. Again, casts are accumulation of these RBCs from the damaged tubes. I'll get to that in the next few lectures, so don't worry. So glomerular diseases again can be classified into nephritic, nephrotic. This is the whole summary of having, so these syndromes are under nephritic, this is under nephrotic. This is a very easier way to study the whole lecture in general. It gives you an idea of which one is where, so try to memorize that. Also, so one of them, so here nephritic, you have post-streptococcal, which will come to, an IgA nephropathy, so be careful of the names. Membranoproliferative MPGN, glomerulonephritis, even though it is nephritis, it is it's a mixture of both. Now, the way I used to memorize that was because it was a longer name, it's the longest name, so it's a part of both, okay? And the other thing that I circled here, so we'll start with nephrotic, that's actually why. These are the primary causes of nephrotic syndrome, meaning that there are no other causes. It just happens, it's idiopathic. It just happens to be in the kidney. There happens to be a damage at the podocyte, right? Nephrotic. The rest of the nephrotic are caused by something else. So things like diabetes, amyloidosis, which is accumulation of protein, and this one, membranoproliferative, which is a mixture of both. Now, the most common, or if, for example, if they give you a scenario of someone coming with edema, hyperlipidemia, hypoalbuminemia, less massive proteinuria, so all these symptoms, and it's a child, that's a very important point. The most common cause of idiopathic nephrotic syndrome is minimal change disease. Like, this is most probably the answer of that question. Of course, there will be more clues, like there could be kidney biopsy, which I'll get into, which will differentiate all of these from each other. But that is just something to keep in mind. Minimal change disease is the most common nephrotic syndrome, especially in children. Okay. So nephrotic syndrome, like we mentioned, we'll mention the pathophysiology first, like what happens, and then we'll go into each disease in detail. Now, what happens in nephrotic syndrome is the damage to where? The podocytes. So these are the podocytes. These are two podocytes, the same here, the same pictures. And the capillary walls as well. The main thing though is the podocytes. So what causes the podocytes to be damaged? There is a theory that the doctor mentions in the lecture where having too much glucose or any sort of damaging factor such as ROS, so oxidative species, reactive oxidative species, anything of that sort can cause damage to the podocytes, increasing, like T cell, like the whole immunity to go haywire, which will cause damage to the podocytes. Again, these are primary, most of them are primary causes, meaning you don't know why the damage happened. But this is just one of the reasons. So having high glucose and reactive oxidative species, which can be damaging in like to a whole, like a lot of other things. Now, okay, so this here, damage to podocytes will cause something called effacement of podocytes. So podocytes are supposed to be flat. They're supposed to be, sorry, not flat. They're supposed to be in kind of like this shape with a flat surface at the bottom, okay? And that makes it have filtration slits where urine can go through. If the podocytes are damaged, they will lose the foot processes here and they will flatten, and this is called effacement. Once you have effacement, that kind of destroys the barrier and the purpose of having, the filtration slits, and they are not functioning anymore as they used to. So there will be loss of proteins in the urine. So now we're talking about nephrotic. So protein is a very, very differentiating factor. So massive proteinuria, loss of protein. What are the causes? The causes can be congenital, like again, it could be congenital, primary most of the time, idiopathic, or secondary to other things like diabetes, immune dysregulation, or structural abnormalities. These are not, eh, we'll get into the most important ones anyway later, so this is just in general. Now there is something different between in nephrotic syndrome especially, and this is all in the notes. So there's something different between children and adults in nephrotic syndrome that is important to remember. So in wait, let me just make sure of this. So yeah, in children there is something called underfill mechanism, whereas in adults there is something called overfilled mechanism. Okay, so so again, like I was saying, there is a difference between children and adults nephrotic syndrome. One of the symptoms here, so that's why it's not like written about like what happens to the blood pressure. So in children, if they lose a lot of protein, a lot of fluids, and they have edema, their kidneys are not functioning as well as adults, right? So the RAS system, which is supposed to bring the blood pressure, the fluids back up, is not working as effectively. So that means the children, they will have hypotension. So that is called underfill mechanism. In adults, however, because the kidney is functioning, it's well structured more than children, in nephrotic syndrome, even if they lose a lot of protein, actually because of losing all this protein and having all this edema, the kidneys will react very aggressively and increase, the RAS system will be activated very strongly. The RAS system responds to having like low blood coming to the kidneys. So again, having edema right here, losing all of this protein, losing all of these fluids will decrease blood to go to the kidneys. So the kidneys will react by increasing or activating RAS system to undergo the whole process of vasoconstriction, these things to kind of bring the blood pressure back up, right? To make up for this loss. So all of this is just to tell you that in adults, the RAS system is activated, causing them to have hypertension, okay, so high blood pressure. Whereas in children, because of the defective, like in mechanism of the RAS, they will have hypotension. That's why it's not mentioned here, like the specific. It's not a specific symptom of nephrotic syndrome, just the differences between them. Okay. Now let's start with the nephrotic syndrome. So these two are showing you pictures of the first most common disease, which is in nephrotic. So they're coming with swelling, edema, loss of protein, and that would be in nephrotic syndrome. The most common one in children is minimal change disease. Now, what do you see here? This is light microscopy. They would appear normal. So this is another stain, that's why it's black here, it's a silver stain, but they would look as normal as the normal glomerulus. So you wouldn't see that much change in the microscope. Wherever here in the electron microscope, you would see a slight change in podocytes. You'll see them, so this looks kind of normal to me, whereas if you compare it with this one here, do you see there is no the filtration barrier, like the slits that are supposed to help with the filtration of urine is not there. There's flattening or effacement of the podocytes. So these are the podocyte foot processes. This you cannot even see at all, and that stops or impedes the filtration of urine. So that's what you see here, and that's in minimal change disease. What is important is that there are no immune deposits. This will come later on. So it's not an immune, this effacement is happening due to, again, things like idiopathic. So there's no known reason for that. Now, for minimal change disease, again, it's important in children. There's no hypertension, especially in children, no hematuria, normal kidney function, everything looks normal, but they present very severely with all the symptoms of nephrotic syndrome. What is the treatment for minimal change disease? Even without, taking a biopsy or confirming from the kidney, if you see this and if you see the symptoms of nephrotic syndrome, you can give steroids, and I think high dose steroid for around 4 weeks, and 90% of the cases it will resolve on its own with the steroid. So they are very steroid responsive. Now, okay, so the next nephrotic syndrome, this is the second one. I don't know if you can see here, but this is very clear. But you can see that at least half, if you compare it to the normal one, half of it looks kind of like more denser. We call this sclerosis. It's like hardening of the structures in glomerulus, whereas this part looks normal. Here, again, you see this part is not normal. The rest of the glomerulus looks fine. Here, these are two glomeruli. This one, there's part of it that's not that looks very dense and sclerotic, whereas the others look normal here as well. If you see glomerulus or glomeruli that's like half damaged, half abnormal, half normal, endosclerosis and hyalinosis, the same thing. So dense material. In half of the glomeruli, we call this disease focal segmental glomerulosclerosis, FSGS. So from the name, you have sclerosis and they are focal, so only a part of the glomeruli or part of the whole kidney as well. A part of the glomeruli is damaged and not the entire glomerulus. Okay, so if you see those, that's a sign of focal segmental glomerulosclerosis. Now, some important things to know, and I wrote them here in the notes here. If in the question stem, it's very important to know this because they could present this way. So they would come with all the symptoms of nephrotic syndrome, and they're adults, right? What increases the risk of having FSGS are things such as ethnicity. So African Americans are higher risk, Hispanic population, HIV, heroin, sickle cell, obesity, and diabetic patients or people are at risk of FSGS. Okay. Um, and the protein that is lost is not specific to albumin. It is a loss of general proteins. So why do I mention that? Is because in minimal change disease here, it is selective. It is only albumin. Most of the time, it's only albumin that gets lost in the urine. So it's very, very specific. This one is not specific. That's why I wrote non-selective proteinuria. Okay. So remember how I said it could be caused by hepatitis, HIV, HIV, heroin, sickle cell. These are risk factors. So if this is a cause of caused by the secondary causes, the most important thing is to treat those first. So treat HIV, treat, for example, like stop heroin, for example, treat the sickle cell first attacks, and then treat those first in secondary causes. If it's primary, if it just happened to be without any of the risk factors, without any cause, again, steroids and other immunosuppressants would help resolve this issue. And yeah, that is it for focal segmental glomerulus. Now, in electron magnetic imaging, you would see the same thing. Again, with all nephrotic syndromes, you would see effacement or flattening of photocytes. There's no clear differentiation of the foot processes. That is the problem here. See, there is no, it's supposed to look like foot if you remember the normal, but here it's just flat. There's no real barrier or filtration slits, and that is what is affecting in this disease. Okay. Now, the next one that we're gonna talk about, if you try to see what you notice first thing when you see this and this and this. So you would see the capillaries are not as thin as before, right? So these are not sclerosis, but this is just thickening of the capillaries in the center. So the mesangial cells near the capillaries, there is thickening of the basement membrane. So diffuse thickening of the glomerular capillary wall. Along with, you would have a new thing, so deposits, and you would have something called, I'm coming to that in a bit. But basically, the first thing that you see, if you see thickening of the basement membrane, thickening here, here, the same thing, this is something called membranous nephropathy. Now, you can remember that by thickening of membrane, so membranous nephropathy. This is what you see in light microscope, and then in the electron microscope, there is a reason for the not reason, but not a cause, but as in there's a reason why the glomerular basement membrane thickens. It's because of like a reaction to deposits. So membranous nephropathy has subepithelial deposits, meaning this. So some of the times it can so a better way to explain this actually is membranous nephropathy is an issue that is most of the time associated with something called anti-PLA2R like antibody. So antibody for this receptor, phospholipase A2 receptor. That is very important to know and a very important association because this antibodies will form will clump together, forming immune complex that gets deposited. So these depositions is what causes the loss of the filtration barrier, again, one, and the thickening of the basement membrane. And the third thing it causes is a certain characteristic like feature of this disease, which is spike and dome. So you would see these deposits. So these are not normal. These are deposits along the membrane. We have never seen those before with the other two. So membranous is the first one we see, and these are specifically subepithelial deposits. So it is beneath the epithelium, beneath the podocytes. So here you see capillary, basement membrane. The purple ones are the podocytes, right? So beneath that epithelial layer or the podocyte layer is the deposits. So this is what causes the spike and dome appearance. So if you see here, it's causing kind of like spike and dome shape because of these deposits that are placed behind the podocyte. Just to like quickly summarize, the capillary part is called endothelium, so don't confuse that. This is basement. Epithelial is the podocyte area. So anything epithelial is near the podocytes. So again, if you see these three features, that is under membranous nephropathy. This is immunofluorescence. So if you stained the kidney, like let's say the biopsy, these immune complexes would light up. Okay, so that just shows that there are deposits present along the capillaries. Now, this association is important, right? This one, anti-PLA2R. This membranous nephropathy can be also secondary to some other things like drugs. So NSAIDs, someone taking penicillamine, which is a medication, malignancy, SLE, all these can form immune complexes which can cause membranous nephropathy. And it is higher in risk for Caucasian, whereas the FSGS was for African Americans and Hispanic. Okay, so that's again another point. For treatment, it's most of the time conservative. Um, if it's like you can also give ACE, it's not as important to know the treatment, but it's a general idea. So I just want to mention here, like I just want to show you because it's cut off, but there's prednisone down there. I'll fix that. So essentially steroids first thing, and then other things like anticoagulation, diuretics, for if it's especially if it's a secondary cause. Now, yeah. So again, anticoagulation, you can think of this is because we are losing proteins in nephropathy, you're also losing clotting factors. So you would want to give anticoagulation so that the patient or the person doesn't bleed out, right? So far we mentioned, minimal change disease, focal segmental glomerulosclerosis, and membranous nephropathy. Primary cause most of the time. Secondary can be to other things like drugs, autoimmune, but most of the time it is primary. Okay, but it is important to know the associations for secondary and the risk factors, which I wrote down below. Okay, so now we've covered the first three most common nephrotic. Um, the investigations in general for nephrotic, you do not need to take kidney biopsy because, like we mentioned, they are responsive to steroids. So if you see a nephrotic picture, immediately give steroids you don't need to take the biopsy at all. Sometimes if it's not responsive to steroids for 4 weeks and it keeps happening again and again, let's say it's a different clinical picture, you can do a biopsy to make sure it's not due to underlying causes such as autoimmune, SLE, and things like that. Some of the complications of nephrotic syndrome, which is important, the number one thing is infection, because you are losing immunoglobulins or proteins in the urine. So the body would be at risk of infections, including peritonitis, which is infection of the peritoneal cavity. And again, you are severely losing fluids or volume, right? So that's another thing. Another important complication is venous thromboembolism. Again, loss of anticoagulants, loss of all these different types of proteins is going to cause increased risk of thromboembolism, infection, and so on. This will ultimately, it can cause acute kidney injury because the kidneys are being damaged if they are not treated. Okay, so this is why we mentioned anticoagulation as one of the treatments in nephrotic for because of this reason. Now, the treatment is first treat symptoms. So if someone is coming to the ER, let's say with edema, swelling of their eyes, and very severe edema, the first thing that you want to do is treat the symptoms, right? So that is another reason why we mentioned here diuretics, right there. So diuretics will let the fluid or the edema to resolve. That's first thing. So again, there's a reason for all of these drugs. The most important thing, definitive treatment, is most of the time steroids. So see if autoimmune, cortisone, if it's caused by, let's say, diabetes, nephropathy, you would try to control the glucose levels first because these are underlying causes, right? So if it's diabetes, you can control the glucose. If it's autoimmune, cortisone. If it's primary cause, also steroids. Okay, that's the summary of nephrotic syndrome. Moving on to nephritic syndrome, I highlighted this so you can always remember inflammatory reaction, and which causes injury to the capillary walls. So now we moved from the podocyte to the endothelium. So now it's capillary and mesangial cells. This loss of barrier is going to have loss of blood in the urine. So nephrotic was loss of protein. Nephritic is loss of blood, so hematuria, most of the time, like more than the protein. So this is another picture showing you that it can be caused by, you'll see the causes now. Most of the time, immune complexes, infection, things that can predispose to nephritic syndrome. Again, inflammation. Anything that can cause inflammation of these two things is nephritic syndrome. Okay, so what do you see here? Here, this is the first nephritic syndrome that we're going to talk about. So here you will see proliferation, right? So it looks very crowded with cells. That's one thing. Not as normal. So that would be like proliferation of the mesangial capillary cells, right? So that looks like inflammation. Another thing, you would not see this everywhere, but here there happens to be a deposit. Here, deposit. In the electron, there's a deposit. Even this is a deposit. And then immune fluorescence, you would see lighting up of these deposits and in a granular like pattern. All of this is just to show you that there is inflammation and there is deposits, right? So this is due to post-infectious glomerulonephritis. This is one of the most common causes of nephritic syndrome. Most commonly, it will come with in a child again, recovering from an infection. How long after the infection? A few weeks. So 1 to 4 weeks after recovering from an infection, most likely a group A streptococcal infection. So it could be throat infection, sore throat, they would say like I had history of sore throat 4 weeks ago, or I would have like they had skin infection caused by the same bacteria, so skin infection 3 weeks ago, and then they present with what were the symptoms of nephritic syndrome? Things like hypertension, hematuria, and proteinuria, slight proteinuria, along with inflammation, like kidney function impairment, right? So these are the features they would come with this, and they would have history of infection. Now, here are the hallmarks of this disease, which is diffuse glomerular involvement with cellularity in both endothelial and mesangial, and you would have inflammatory cells, neutrophils around. There are deposits, again, this is subepithelial. Even though the endothelial is being affected, just remember this is subepithelial on the side of the podocytes. What is the treatment for this? If you see these features, it's mainly supportive, um, kind of supportive treatment, and the prognosis of this is spontaneous resolution. So if you treat, if you give them fluids, if you treat, the loss of protein, loss of blood in the urine, they will most likely resolve on its own, because this is again an inflammation, so it will go away on its own after the infection is gone, right? So that's post-infectious glomerulonephritis. I'm trying to see if, like, to make sure that I didn't forget anything, but they're all in the notes that I put. So these depositions, the deposits, are from the so because they had the infection, again, it's like a delayed response. So these immune complexes build up, mainly IgG, IgM, and C3. So you know how in Streptococcus infection, these are these react to the infection. So that these are what the deposits are made of. The other thing is, if you test for specific markers for Streptococcus infection, such as anti-streptolysin O, so these are markers for this bacteria. So this is again another specific feature of this syndrome. That's mainly it. Just remember where the deposits are. So subepithelial, even the one in membranous was subepithelial, but they had thickening of the membranes. Here it's hypercellularity, so proliferation of cells only without thickening. Okay, that one was nephrotic, this is nephritic. Okay, moving on to this one. This looks like it's thickening of, right, the membranes, but the scenario would be a bit different. So it would be someone coming with throat infection in general, and 1 to 3 days after this infection, they would present with nephritic syndrome, right? So hypertension, hematuria, slight proteinuria, not nephrotic. So nephritic 1 to 3 days after infection with this picture, right? With this picture and the deposit picture should give you a clue for IgA nephropathy. Now, IgA nephropathy occurs within 1 to 2 days again of infection. Post-infectious or post-streptococcal glomerulonephritis was weeks after the infection. One way I like to remember this is because it's A, like A is the first letter, so it's very fast. So A is 1 to 2 days. The one with the long name, post-infectious, is longer, so weeks. Okay, so just remember A is short, like A is quick. This is again one of the most common causes of nephritic syndrome, even though it says nephropathy. Just remember that. This is mesangial widening and proliferation at the same time. So you have widening of the mesangial cells. You see a little bit of thickening here and there, and proliferation at the same time. Immunofluorescence is specific for IgA deposition. So that is another difference from the post-infectious. So post-infectious was C3, IgG, IgM due to the infection, resolving infection. IgA nephropathy is specific. So if this was stained with IgA fluorescence, it would light up. If it was stained with IgG, it would not light up. That's the point, right? Because they look the same here and here. It's just the type of stain that you use. So again, specific IgA nephropathy. If you see this, that is important. Now, there are some instances where so the reason for this is because IgA, immunoglobulin A, is not being cleared as quickly, and it's being overproduced. Okay, so that's why the body recognizes it as an immune foreign body, and they will form complexes against this IgA. This is also called, I have it all in the notes. This is also called sometimes burger, I don't know how to say it, but that's the idea. uh Burger syndrome, something like this. It is the same like disease. uh what is the what are some of the causes? I wrote some of them here. So again, you have overproduction or under secretion of IgA, so elevated levels of IgA due to, it could be galactose deficient. So these are, again, I don't think they will ask you this, but I just wrote it just for the sake of completion. Um, again, this is like it's a defect in clearance of IgA, that's why. So it produces autoantibodies against this foreign body, forming immune complexes, and then these get deposited everywhere. So that is why you have this disease. Okay. Okay, so we mentioned nephritic syndrome, we said post-infectious, and we said the IgA nephropathy. So I just want to go back here to show you what we covered so far. Here we covered this and this, right? Now, in the lecture itself, the doctor did not mention diffuse or rapidly progressive, so I will not touch upon that if that was not the focus of the lecture. As well as Alport syndrome, which is a genetic condition. Just know that it is nephritic syndrome, okay? Associated with things like other congenital diseases. So a baby could be born with deafness, and things like that. So that is again, it was not mentioned, so I will not touch upon this as much. The most important probably that you will get asked on is the 1 and 2. Okay, so that's where we stopped. Um, so let's move on to systemic diseases. Systemic diseases are things that are causing or affecting all parts of the body, all organs, such as SLE, diabetes, amyloidosis, and something called Hinox-Schulin purpura, so or HSP. Okay. Now, okay, so moving on to, so some of them, like diabetes, for example, is nephropathy, so nephrotic syndrome, amyloidosis as well. You will see in the first different like differentiation. Amyloidosis is also a part of nephrotic syndrome. Okay. So SLE is a very interesting disease because it affects a lot of the organs in the body, and renal is one of them. Kidney is one of them, in 50 to 70%. The main problem with SLE is it's an autoimmune disorder, so it would have autoantibodies. It's chronic, it's relapsing. It affects it specifically. It has a criteria for SLE, including something called some things like rashes in the body. So this is called discoid rash. This is a malar rash. Malar rash is like a butterfly kind of rash that is sparing the nasolabial fold. If you see this, that is most of the time most likely SLE, specific for SLE. Again, these autoantibodies will form immune complex deposition by all these antibodies in the glomeruli. So they will come and sit in the glomeruli, causing the renal damage. And you will see deposits as well. Okay, so we will see the difference now. So these are the classes of SLE affecting the kidney. So lupus nephritis. So SLE in the kidney. There are different stages. So class 1 and 2, I like to group them together because they are minimal and they only affect the mesangial cells, so the inside cells. Class 3 and 4, I will come to that in a bit. So it's more extensive than 1 and 2, and 3 is focal, 4 is diffuse. So 3 is affecting part of the glomeruli, whereas 4 is affecting the entire glomeruli, so diffuse. And then we have class 5, which is the same as membranous. So remember in membranous how we said that SLE was one of the risk factor? This is it. This is the same disease. So SLE here, class 5 is nephrotic syndrome, right? Membranous. Class 6 is the most severe one. It's the advanced sclerosing disease. We never got asked about it a lot. So the most important thing is 3, 4, and 5 to differentiate. So 3 and 4. So we mentioned 1 and 2 are minimal mesangial cells. It's not causing nephritic or nephrotic that severely. It's just the mesangial cells are increasing in number. 3 and 4, so we group them together because they start to produce symptoms of nephritic syndrome. So proliferative nephritic urine, inflammation to the capillaries and the basement membrane. 3 is focal, so only a part of the glomerulus that is causing the nephritic syndrome. 4 is diffuse glomerulus causing the symptom. Type 5 is the membranous, the high risk patient, right, for membranous. So nephrotic syndrome is here. So SLE is a mix of both. You can put it under both when you make the table, just because it has different types. Okay. Okay. Now, this is a combination of all the things that you'll see in lupus or SLE nephritis. Okay. And generally, you will see. So if you had to guess which one is which, I'll show the answers now anyway. But this is part of the glomerulus. These are kind of all, right? All of the glomerulus, all of the They will not ask about one or two. They will most probably ask you to differentiate only between the focal and the diffuse. So the focal we said was SLE type. So that's another example. I will show it now. Focal we said was type 3, nephritic, and diffuse, this one type 4, the diffuse one is type 4, still nephritic. Okay. Okay, so that's very clear, right? Now, the reason why I put the images here, obviously you'll see deposits of everything, deposits of all the autoantibodies that is in SLE. So it is, we call SLE a full house, like immunoglobulin, like positive. So it, if you stain it with anything, if you stain it with IgG, IgM, C3, C4, all of it will light up. So we call it a full house. SLE is very complex. It has everything. It has all the complexes, if you will. This is diffuse. This is also diffuse here. So we call it type 4 nephritic or diffuse SLE, lupus nephritis. All of this is the same thing. Here, a differentiating factor again, here from here and here, is you will see something called wire loop lesions. So they look like loops, right? Loops of wire. This is part of the type 4 or diffuse. And that's because it is, like, again, reacting to these immune deposits. So again, full house, everything will light up, wire loop lesions, and you have deposits. Any immune complex disease will have deposits. This time, however, it is in the subendothelial. So this, these deposits for SLE are coming from the blood, right? It is in the blood. It will deposit in the endothelial or the capillary side. Okay. So again, like we mentioned, subendothelial deposits here in the capillaries and the wire loop lesion, full house, right? Okay, that was for SLE. The whole thing was for SLE. Now, if you see this kind of picture and the patient presents with things like rashes in the legs, they will come with other renal abnormalities such as hematuria, nephritic and nephrotic, so mixture of both again. And if in the staining it's IgA specific deposition, that is, it's similar to IgA nephropathy, remember, from nephrotic syndrome, but it's in combination with a lot of other symptoms like rashes in the legs, hematuria, so kidney function impairment. It could be nephritic, nephrotic, uh, and the other thing was abdominal pain. So if they come with abdominal pain and all these symptoms, you should think of henoxylane purpura, so HSP. HSP is again another disease that is a systemic disease. It's affecting multiple organs at the same time. And in the light microscope, you will see, I know it looks similar to all the rest, but you will see segmental necrosis. So very brighter pink signifies necrosis with fibrin or a protein like accumulation. And crescent means okay, so that was, so just remember that it looks like it is, something is covering it, oh, like a crescent. Okay, so there's a distinct shape. I know it's not as clear here, but distinct crescent-like shape with necrosis, surrounding necrosis, and fibrin exudation. So all of this is obviously the scenario will come with other symptoms, so rash, IgA specific. This will point you towards HSP. Okay. Now, HSP happens after, again, an infection. There's no specific timing, but there can also be like joint pain, these rashes, abdominal pain, and the renal abnormalities. Okay, so if you see that, that's HSP. We talked about SLE, right? So one of the other things in the systemic was this disease. So if you see thickening of basement membrane, what do you think this is? And if you in the light microscopy, it would show up like this, right? So without deposition. So you see it's diffuse thickening of basement membrane. We never saw that before. It was always diffuse capillary. So this is diffuse basement membrane thickening with no deposition, right? So there is no complex, there is no deposits, unlike the membranous. So membranous was thickening as well, but with deposits in the sub epithelial. So here there are no deposits at all. You should think about diabetic nephropathy. So diabetic nephropathy, again, the patient will come with polyuria, polydipsia, things like that, diabetic like symptoms, right? Along with these. So these two main points. So no deposition, diffuse thickening. This matrix depositions, I don't mean like the immune depositions, but I mean that the thickening itself is PAS positive. So it will stain pink in this stain. Okay. This diabetic nephropathy, this stage can lead to other more severe like renal damages such as diffuse mesangial sclerosis. So it can cause sclerosis in the long term and nodular glomerulosclerosis. So these are again parts of the diabetic nephropathy, but they're all under the same class, which is this. So the why I mentioned that is because of this. If you see someone progressively getting worse, like diabetic nephropathy getting worse, and you see on the biopsy or the light microscopy, you see pink like nodules, very bright pink nodules. Here, very light pink nodules as well, because of the difference in stain. Here, big like accumulation of nodule-like structure. That is called this one, nodular glomerulosclerosis. So that is the last kind of stage for diabetic nephropathy, nodular. So from the nodules, okay? And it has a specific name called Kimmel-Stein-Wilson nodules. This is specific. If you see this, it's immediately diabetic nephropathy, okay? And there are some things called fibrin caps, capsular drops. I'll try to explain that, but basically, because of these nodules, like this accumulation of fibrin, they sometimes form caps. So like very distinct structures capping the glomerulus. So this is fibrin caps and capsular drops as well. Now, again, wait, sorry, yeah. Capsular drops are the one, so this one I should have labeled it, but it's the one that is adherent or sticking to the Bowman's capsule. So the Bowman's capsule is the white structure here, right? If anything is sticking to that, that is capsular drops. Fibrin caps are the capping of the glomerulus themselves, okay? They're more of like capillary loops. You can also mention that. And what else is there? The treatment for diabetic nephropathy, if someone is coming with very severe symptoms of renal failure, you give ACE1 because that will lessen the load for the kidneys. So ACE inhibitor, by ACE1 I mean ACE inhibitor, it will lessen the fluid on the kidneys by dilation of the arteries, right? So that the kidneys are not stressed with all the fluids that is coming to them, plus SGLT2. Both of these are to treat or target diabetes in general and lessen the load for the kidneys. Yeah, and that is mainly it for diabetes. Now, another thing that I forgot to mention here, um, the first cause of mortality, again, especially in diabetes, is CVS first, and then secondly is the because of the kidney diabetic nephropathy. So these type of patients, they will most likely die from cardiovascular diseases first, and then this complication. Why? Because again, CVS is more critical. It can cause hyperlipidemia, which can go back to the heart and cause atherosclerosis and so on. Okay, now this is another systemic disease. And you would see it, this was, I think, in the lecture like this. But basically you would see very red, bright red, eosinophilic and hyaline extracellular substance. So outside of these kind of cells, you would see material that feels like you see it's like being deposited. It's like bright pink. It's not like the ones we saw before. It's not thickening. It's not immune, right? It's something that is being deposited like very haphazardly, randomly. So that is and very huge. So amorphous, very, very big deposits. Um, and there's a special stain here which you will never see in anywhere of the other diseases. So this is called Congo red stain. Um, if you hear these two words, you would know that the systemic disease is amyloidosis. Amyloid itself is a protein. If you have overproduction due to immune response, decreased clearance, this amyloid will start accumulating and depositing everywhere. So it will deposit in the kidneys, forming amyloidosis in the kidney, like in the kidneys problem. Now, the stain you use for amyloidosis is special. You can see it pink red only on the congruent stain, right? So that differentiates it from the rest in the first place. So congruent stain will have pink or red. Now, if you polarize under polarizing microscopy, so if you change the polarity of the light, there are special filters for it. The color will change from the pink red to green. And amyloid protein is the only specific protein that does this change. So green birefringence under polarizing microscopy of the Congo red stain is amyloidosis. Now, this again, amyloidosis, it can come as a case of someone with multiple myeloma. Multiple myeloma is a cancerous, like it's a cancer of the plasma. Again, I'm going off topic, but basically, multiple myeloma is it will cause accumulation of amyloid. Alzheimer having beta amyloid in the brain accumulation, the same thing, amyloid protein. Another example of autoimmune disease is rheumatoid arthritis that can also cause accumulation of proteins. Okay, so there's a lot of things. Even tuberculosis can cause accumulation of amyloid proteins. And this can all cause this disease, amyloidosis. Just remember this part here, the stain, and that it can change under the light to green. So this way we finished glomerular diseases. We covered nephrotic, how to differentiate the deposits like position, how to treat some of them, like generally. Not you don't have to go into more specific details, but these were the most important things from the lecture. This is a summary showing you definitions. So, for example, saying focal means less than 50, diffuse is more than 50. This one, another example other than these two that I can give you are in diabetes. So diabetes type 3 and 4, one of them was focal, less than 50. Type 4 was more than 50, diffuse. Proliferative means hypercellular, which we saw, or at least we saw it in post-infectious. This is another example, again, the MPGN, the longest name. From the name proliferative, it is hypercellular glomerular. Membranous is thickening with the deposits in the in the subepithelial near the podocytes. So that's membranous nephropathy. Primary is primary disease of the kidney, mostly minimal change disease is the most common nephrotic syndrome. Secondary is due to other things like SLE, diabetes, amyloidosis, systemic diseases are most likely secondary glomerular disease. Okay, I hope that was clear. Because now we'll move on to cystic diseases. So cystic diseases of the kidney will start right away. And it's important because, again, I'm going to focus on the pathology. So there will be a lot of pictures and things like that. Okay, so again, let's start with the simple cysts. I'm not gonna go with we'll see now. So this is, again, just remember the normal. So cortex, medulla, it's supposed to be cortex and medulla, sorry, cortex, medulla, and pelvis. Here, you cannot tell the difference at all, right? So it's just cysts all over the kidney, and there are hard structures like cartilage, um, abnormal structure in the kidney, which shouldn't be there. So this, if you see this, for example, these are example of cystic diseases. Cysts are fluid-filled structures. So if you see this one all over the kidney with abnormal structure hanging out, this is most likely, we saw it, but multicystic renal dysplasia. I'll go back to that point in a second. However, this one, if you see simple one smooth rounded cyst, here this is small, this is big, see, smooth and contoured, only with fluid inside of them. There's no solid, there's no signs of malignancy. This is simple cysts, okay? However, and we'll see the difference now. So this one here is dysplasia, this one is a simple. And yeah, just give me 1 second. So yeah, my point was, so I'm just starting with these to show you the difference of how simple can be different from a complete dysplastic like dysplasia like cyst. Okay. Most commonly, if someone comes with no symptoms, nothing, they find incidental finding of like a cyst in the CT scan, like without, no symptoms or anything like that. That is simple renal cyst. If they had to take, let's say, someone, in autopsy, for example, they took the kidney, it would look like this. Generally, we would not touch it if the patient is not symptomatic, but this is how it would look like on if they took it out. So simple renal cyst, only fluid, smooth border. This one, on the other hand, to show you the difference, you cannot see the differentiation, you cannot see the cortex, and you have abnormal structures or immature structure. So this, we will call it multicystic, cyst everywhere, dysplasia. So different cells, different kind of cells are showing up. And in the histology itself, you will see, so these are, again, other structures that shouldn't be there, like fat cells. There will be cartilage, and uh, these kind of like different cells other than the kidneys themselves, right? So that's why we call it multicystic renal dysplasia. Now, okay, I'm just trying this. Yeah. So here, these are different sized cysts. Oh, sorry. So these are not fat cells, but these are different sized cysts. So again, multicystic refers to size as well. There is cartilage here, so it would show like as different kind of structures, very pinkish. Um, yeah, here, this is the cartilage, sorry, and this is the mesenchymal structure. So it's like a additional structure that shouldn't be, more like dysplasia. Okay. So again, cartilage, different sized cysts, and others. Sorry, I was just trying to read the notes from the pathology lecture and why they were highlighted. That's why. Okay, so moving on from the simple cyst and the multicystic renal dysplasia, these two are the most common or the most important high yields from this lecture. One of them you will see very, so this is a kidney, like if they were cut, this is the two kidneys side by side, you would see cysts all over the cortex, very big cysts, and the cortex is not smooth at all, and it's bilateral. So all of these features, and then when you cut it, there will be things like stones, calcifications, and cysts all over again. um, that is, we call it polycystic kidney disease. There are two different types, so this is one of them. The other one here, if you see it, you'll see smaller cysts. So these are the kidneys. There, the cortex is smooth, right? It's not as cystic as this one. The cysts are, once you cut them, you will see all these cysts inside, and then there would be smaller than these cysts as well, so smaller and smooth cortex. Uh, that is another type of polycystic kidney disease. Now, we call this one, the one that is bilateral, irregular, contour, autosomal dominant, or adult polycystic kidney disease, whereas this one that is more smooth, smaller cyst, autosomal recessive. So this is dominant, more severe. This is recessive, and in childhood, more of the time in childhood, most of the time. Um, Now, why do we differentiate between these? We mentioned already this thing. So the reason why we say adult is because it shows up in adulthood. So a person would be living like normally with no symptoms until the age of 40 or 50, where they will start to have symptoms. When they investigate, they will find out that this person has been like this their entire life. It just showed up very late. That's why we call it adult or autosomal dominant. Um, what is important here is two things also. Chromosomes. I have a table at the end that is highlighting the chromosomes in general. So chromosome and the location and the genetic mutation. So someone having PKD1 or polycystin-1 protein is being affected. That is the most common mutation. The second mutation is polycystin-2 or PKD2 located in chromosome 4. These two predispose to this condition. Okay. The other thing that is important is these patients are most likely to have liver cysts, so cysts in the liver as well, and aneurysms in um, the intracranial arteries. So they would be berry aneurysms. So aneurysms are widening of the capillaries, so they would have those as well in the intracranial circulation. For autosomal recessive, these are not as common. Berry aneurysms are not as common. They could have liver cysts, but the main difference in the kidney are the smooth surface and having smaller cysts. Once you cut the kidney, you will see that it is full of cysts, right? Uh, what is the difference again? Even though it looks smooth and it looks less severe, uh, in reality, it presents in childhood. So these infants, pediatrics like population will be very affected. It's very serious, and it will quickly go into rapid renal failure, whereas the adult one was until 40, 50, they were living a normal life, right? So that is the difference. So even though this looks smooth and it looks smaller, it is more severe because it presents in childhood. Okay. Now, this is the difference in histology and in imaging. So in histology, in the adult one, again, like I said, it presents later. So there are normal glomeruli within the abnormal. So it looks not as bad as this, right? So this looks very differentiated. It looks at least like normal glomerular. It has a glomerular function. So a complete nephron can be present even in between all these cysts. That's why it has kept them working or kept the person's kidney working for a long time. Whereas autosomal recessive polycystic kidney disease is very not differentiated. It appears very early in childhood. So you will see that a whole nephron is not formed, and it's very severe renal failure. In imaging, you would see multiple cysts here and here, starry sky pattern on ultrasound showing cysts filled with fluid, many cysts in childhood. Okay. That's it for these two. So we mentioned polycystic kidney disease, adult childhood, cysts in the cortex of the mainly the cortex of the kidney. Now, cystic diseases of renal medulla. We have these. So we have three types actually. So there's medullary sponge kidney, nephrophthitis, and adult onset medullary cystic disease. I know I'm just saying them, but these three are the most important cysts in the medulla. And yeah, we'll differentiate between the all of them. So here, what you see here is cysts in the medulla only, leaving or sparing the cortex. So multiple cystic dilations in medulla. In the imaging itself, you will see cysts in the medulla. You will see brightening. Here it was in the cortex, right? This one is for the polycystic. This one, medulla specifically, it's only in the medulla, in the middle part. And these ducts are lined by cuboidal or transitional epithelium. That's fine. That is one type of the one that I mentioned in the renal medulla. This is called medullary sponge kidney. So it's only in the medulla, so it's like a sponge in the middle, right? So that's medullary sponge kidney. Now, this one here, however, the cysts are not completely in the medulla like here. They are in between medulla and cortex. So you will see cysts like in middle of the cortex and medulla without it filling like this one. So that is called medullary cystic disease. So cysts between cortex medulla, autosomal dominant. These two are the genes, and they present later, older age presentation. These genes are again listed in the table. So this is again medullary sponge kidney. It looks very much like a sponge in the middle. You can remember it like that. This one is only medullary cystic, so few cysts in between the junction, in between the cortex and medulla. This is the same picture for medullary cystic. The third one that I mentioned was juvenile nephrophthitis. Nephro Nephritis. So this is autosomal recessive. This one was autosomal dominant. Okay. So medullary cystic, the one that presents older age, is autosomal dominant, whereas juvenile, so younger age, is autosomal recessive. It appears earlier in juvenile. It has three different types. So juvenile, one in adolescence, and one infantile. So caused by three different genes. And because the name here of ophthalitis comes from retinal problems. So if you see that, you would know that it causes retinal disorders as well. Presentation would be very early and it would come with renal failure very early on. So that is again autosomal recessive, more severe. Medullary cystic autosomal dominant, less severe and older presentation. Same like with polycystic, this one was dominant, less severe. Recessive is more severe. Okay. Both these two, the reason why I put them here together is because they present similarly. They come with polyuria, which is like urinating a lot, like frequently. Polydipsia is thirsty. The person is very thirsty all of the time. And the cysts here are at the junction. Both of these are at the junction. The only difference is presentation and the genes. Not presentation, well, presentation of age. When does it come? And the genes. The treatment for these two is most like you cannot kind of reverse the genetic mutation, right? So it's most of the time just supportive therapy and replacing the salt that is lost. So because this person is having renal function like impairment, polydipsia, polyuria, you would try to replace the salt that the person loses. Okay, so far we mentioned, just as a recap again, simple cyst, the most common finding, incidental finding, multicystic renal dysplasia, then cortex cyst, the one that looks very severe but is not actually, it presents very late, is autosomal dominant polycystic. And then here in the cortex as well, it's smooth contour, but it appears very early on. It's autosomal recessive polycystic kidney disease. Moving on to the medulla, we mentioned that there's three types. There is medullary sponge, the one that is filled in the medulla. Then here it is medullary cystic, only in the junction, and juvenile nephrophthitis, which is early on, and it has retinal disorders as well. Okay. Yeah, these three are renal medulla. Okay, now what do you see here? This person presented with, let's say, end-stage renal disease. He was on dialysis for a long time for, let's say, kidney failure, for diabetes. He was on dialysis or hemodialysis, and they come with these kind of cysts in the middle with crystal, like very, very bad calcium oxalate crystals and stones in the middle. The clue that leads you to the diagnosis is that the scenario of having been on hemodialysis and end stage. So this is acquired dialysis associated cystic disease. So this happens because of the dialysis, the long-term dialysis, and it's acquired. It's not genetic. It's just because this person has been on dialysis for a long time, that it causes failure to the kidneys. It has renal cysts. Another important association is that this has increased risk of progression to tumor or renal cell carcinoma within 10 years of starting dialysis. Okay, so be mindful of that. Renal cell carcinoma is, again, we are talking about cysts. So this is, carcinoma is a whole another thing, right? So it's tumors. So this way we finished the cystic disease lecture. Another important thing to note is renal function test before we move on to renal damage. So we said glomerular diseases, we said cystic diseases of the kidney. We want to know how to differentiate between damage in the kidney and damage in the tubules by renal function tests. Renal function tests are things like blood urea nitrogen. So all of these things are um, normal just because the kidney is supposed to clear them, right? If the kidney is not able to clear them or filter them or absorb or secrete, there will be something wrong with all of these markers. So blood urea nitrogen, creatinine, here there would be protein in the urine, blood, and WBCs, pyuria in the urine, and casts, which are accumulation of abnormal cells or accumulation of damaged cells. Okay. What is the most important, or what is the most important thing to look at is the creatinine clearance. From this whole lecture, that is the most important part. Having clear creatinine clearance, so a normal kidney is supposed to clear creatinine, right? Creatinine clearance is the amount of creatinine that was cleared from the blood. It's very easy to measure. You can just measure it and see how much creatinine was cleared from the blood by comparing it with the urine. This ratio of creatine clearance is important because it reflects an important function of the kidney called glomerular filtration rate, so GFR. GFR is reflected by creatinine clearance. This is an estimation of GFR, and it's the most reliable renal function test. We always do it in every disease to see, just to see the functionality of the kidney. There's another thing. So you can do BUN, creatinine ratio. That is also a good indicator of renal function test. But the most important one is creatinine clearance because it is a direct estimation of the filtration function, GFR, of the kidney. That's because creatinine is filtered in the kidney without being reabsorbed at all. So it will filter out into the urine, straight into the urine. So once you measure it, you will know that once you measure creatinine, you will know that this is a reflection of GFR. How do you measure it or how do you calculate it? This is important as well. Uh, for measuring it, you would measure the urine creatinine times the volume of the urine all over the plasma creatinine, so in the blood, over 24 hours. This is very impractical. You cannot let keep measuring over 24 hours in the blood and the urine at the same time, right? So we do something called estimated creatinine clearance. Estimated is just as good. It is actually perfect and preferred to this over 24 hours because you just have to multiply by 72 using fixed values. So 140 minus the age of the patient times the weight over plasma creatinine, only one measurement of the blood, times 72 is estimated creatinine clearance, which is a measure of GFR. You can multiply the entire thing by 0.85 for adult females. It's just a constant value for them. The normal is between 97 to 137. And if, okay, so this is another point that I saw. So if the creatinine is abnormal for a long time, that represents chronic kidney disease. If it shoots up or shoots down overnight, like very quickly, it's an indication of acute condition, like infection to the kidney, things like that. If the creatinine is, not uh not normal level for a long time, that indicates chronic kidney disease. It's important to differentiate that. So you have to look at the trend of creatinine clearance instead of one reading, right? But this is, again, estimated creatine clearance is a very good estimation of GFR, or kidney function. That is that is it from this lecture. It was very short. This equation is called, memorize this equation. It's called the Cockcroft-Gault and MD-RD formula, if I'm not mistaken. But yeah, that's the formula to calculate creatinine clearance. Now, moving on to acute kidney injury, we talked about renal function test. We can now talk about the injury itself to the kidney. Generally, it just means that there is an injury to the kidney. It could be in the filtration, it could be in the tubule part, remember? That could cause a shedding of the cells. So if there is any damage to the whole, structure, the cells would die off, and it would shed, you can say, into the urine themselves. So this shedding of damaged cells can cause obstruction, it can cause back leak, and it can cause the casts in the urine that I was talking about. Okay, that's a general idea. Now, there are three main kidney damage entities that we should talk about. So the first one is, so this is the normal. Okay, so let's talk about the normal first. Normally, you would have BUN, remember, and creatinine being filtered in the kidney. So you would have them come to the glomerulus, they would be filtered. Remember, creatinine is not, it's just filtered completely. There's no reabsorption secretion. So it just gets filtered by the GFR, whereas BUN is it can be filtered as well as be absorbed again back into the blood. So that is the normal. The ratio, if you do BUN to creatinine, remember it's a good ratio to measure the kidney damage if it has been if there is a damage or not. So if you do the ratio, the normal ratio is 15. Okay, so BUN to creatinine is 15. That's because BUN gets reabsorbed, it is higher. Creatinine all gets filtered. There isn't any remaining that gets reabsorbed. So 15 is the normal ratio. What happens if you have uh, damage to the kidney? Now, the damage to the kidney can be classified into three things. It can be before the kidney, so we call it pre-renal azotemia. It can be damage at the kidney, so renal azotemia, or it can be damage after the kidney, so that would be post-renal azotemia. Let's talk about pre-renal. Pre-renal, before the kidney, think about what could go wrong here. There could be, for example, a tumor here, right? A mass that would block the BUN and creatinine from coming into the kidney. So that's one. So having a mass, having an obstruction before the kidney is a problem. Other things that can decrease the blood flow here are things like someone going into shock, so hypovolemia, losing lots of fluid or blood. They would have less fluid coming to the kidney. That is pre-renal problem. What about someone having heart attack, myocardial infarction? Same thing. They would have hypotension, less blood coming here. So myocardial infarction is pre-renal. And things like that. Loss of fluid, dehydration is a good example as well. And yeah, that's mainly it. So those are all causes of pre-renal kidney damage. If that happens, right? If that happens, then BUN to creatinine ratio will actually what? It will increase. Why? Because if the kidney feels or senses that there isn't enough fluid coming in, it would reabsorb all the fluids it can. Because there is hypotension, there's no fluid coming in, it would reabsorb everything, try to reabsorb as much as it can. So BUN reabsorption increases while creatinine is filtered normally because there's no reabsorption. So this reabsorption of BUN increases the BUN to creatinine ratio of more than 15. So if you see that, and if the causes are things like myocardial infarction, hypertension, dehydration, this is pre-renal azotemia. What about if there's damage at the kidney at the site of the kidney? So renal azotemia. That means that the reabsorption cannot work, right? Because the damage is right there. So reabsorption, filtration, there's a problem with both. essentially it cannot get reabsorbed, so the ratio cannot increase, it will actually decrease because there is damage to the reabsorption. So decrease in kidney reabsorption, decrease in ratio. The third thing is post-renal, so azotemia. Post-renal means after the kidney. So think about ureter, bladder, there can be obstruction, mass in the bladder, there can be reflux from the bladder, a lot of things. So any sort of obstruction after the kidney will force the urine to go upwards, right? So it kind of makes the kidney reabsorb everything because there's no way, it can go all the way down to filtration. I hope that made sense. So if there is an obstruction, the liquid will be back flowing into the kidney, which will cause or force it to reabsorb everything. So it will reabsorb BUN as well. So that would increase the ratio back up. Now you might wonder like how to differentiate between pre-renal and post-renal because the ratio both is increasing. It's the causes again. This is pre-renal, this is post-renal, and there is something called another thing, important thing, is the excretion of sodium. Okay. Uh, Here is a summary of everything that I mentioned. So pre-renal is hypovolemia, everything that causes less volume, less GFR, increases absorption. Post-renal is obstruction, so stones, prostatic hyperplasia, cancer. Any obstruction will cause post-renal azotemia with increased ratio. You see, more than 20. This one should be increased ratio as well. Intrinsic renal failure, problem at the kidney due to, we'll get into this in a bit, but do you see nephrotic syndrome falls here? Okay, so problem at the kidney. Vascular problems, tubular problems, which we'll get into now. All of this will cause intrinsic renal failure, causing less reabsorption, so decreased ratio. Okay, one key factor that you can differentiate between all of these three, other than the ones I mentioned, are fractional excretion of sodium. Now, pre-renal here means again hypovolemia, hypotension. So the person will be reabsorbing everything it can back into the body, right? So that means it cannot spare or it cannot lose any sodium in the process. It has to reabsorb everything by the kidney. So that's why excretion of sodium is very, 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 very low. It cannot lose anything, remember? So it's less than 1%. If the kidney is damaged if the damage is inside the kidney itself, it cannot reabsorb. So the excretion of sodium will happen either way, and the excretion of sodium will be more than 2%. That is a very a very key differentiation point, the sodium and the reasoning behind it. Because intrinsic, everything, like even the ratio is low, excretion of sodium will be high because the damage is at the kidney itself. I hope that made sense. So fractional excretion of sodium and knowing the ratios, knowing the causes of each of these diseases is important. Okay. Now let's talk a bit more about the next lecture, which is intrinsic renal failure. So having the damage at the kidney itself. That can be due to two main reasons. So acute kidney injury, we call it. It can, or also called acute tubular necrosis, is a part of acute kidney injury, which is injury at the kidney. Two main causes can be, or three, but categorized into two. So it can be due to ischemic injury, or toxic injury to the kidneys, or as a reaction for as an inflammatory reaction to something. So all of this will cause damage at the kidney site. Where exactly? In the tubular part. We're not in the glomerulus anymore. We're in the tubular part, right? So we are here. So these are three main causes. Here there will be tubular injury. It's the main things, causes we mentioned before: hypotension, ischemia. Any cause of ischemia can be causing ischemic injury. What about toxic? What are some examples of toxic materials that can injure the kidney? These are things like drugs. There are many examples of drugs that can cause toxic injury. Dyes such as contrast used in CT, they can cause injury to the kidneys. Myoglobin radiation, myoglobin in So if someone in athletes, for example, if they exercise a lot, their muscles release myoglobin. It's actually toxic for the kidneys if it's produced a lot, and if the kidneys have to filter it out a lot, it will cause damage to the tubules. Okay, or urinary obstruction. What about inflammatory reaction? That is, again, inflammation, any infection like pyelonephritis, infection of the kidneys, toxins, other sort of like vascular immunology, any inflammation that can cause even UTIs, urinary tract infection, can cause inflammatory reaction. This has a specific name. We will call it tubulointerstitial nephritis. So one way to remember that is again nephritis, inflammation, interstitial cells, inflammation, things like that. This in general is the most common cause of acute renal failure, and it can be reversible, especially because these tubular cells are very fast at regeneration, which is a very, very good feature in like it prevents the kidney from being like from fading, basically. So it's just called injury to the kidney at a certain time. Now, let's talk about ischemia. So ischemia was one of the causes, right? Toxin, ischemia, and inflammation. Ischemia can cause to the kidneys themselves. It will cause less blood to come to the kidneys. The kidneys will react. It will vasoconstrict everything to reabsorb everything, right? To counteract the ischemia. So vasoconstriction is the main key factor. Uh, it will again cause kidney injury. It's by itself, even though it's a defense mechanism. So ischemia will cause less blood to go to the kidneys, less filtration, vasoconstriction happens to reabsorb everything. These are vasodilators that are reduced. Endothelin is vasoconstrictor. It's a damage to the tissues. That's why it's released. And RAS system is activated to increase blood pressure or the blood because of the ischemia. So all of this will reduce vasoconstriction in response to ischemia, will actually reduce the oxygen supply to the tubules. So if there is ischemia here, there is vasoconstriction at the tubules, and the vasoconstriction at the tubules means the cells will die off because they are not getting enough oxygen. I hope that makes sense. So that will cause tubule cell injury, acute kidney injury, tubular necrosis, and so on. Now, like I said, because the regeneration is fast, it can be reversible here, or it can be irreversible if it goes on for a long time. Reversible meaning the cells will shed off slightly. They will detach from the tubules, and they can cause casts to form in the urine. Irreversible will be things like necrosis, apoptosis for a long duration. All of this essentially will lead to reduced GFR, so reduced filtration in general, more reabsorption, or they will at least try to reabsorb. So reduced GFR and oliguria. Oliguria means reduced production of urine because they are trying to compensate for the ischemia. Everything will go back up. So the urine produced will be very little, which indicates injury. It's not a good thing, right? Even if it's a defense. So it's better to treat it as fast as possible. Now, differentiating between ischemic and toxic acute tubular necrosis. I kind of mentioned this before. Ischemic is the one like hypotension, things that are like making the blood not come to the kidney. Toxic are things like drugs, rhabdomyolysis, dyes, contrast dyes, and so on. So anything toxic material to the kidney will cause toxic acute tubular necrosis. So what is the difference between the two? Okay, we'll see it here. If you compare this and this, it's talking about the same thing. Ischemic type will have focal lesions, meaning that, so for example, less blood is coming to the glomerulus right here. So that will cause like damage to the kidney tubules, but very like focal or very patchy. It's not continuous. So it would form ischemia here, 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 here. Whereas toxic will affect the entire thing because the material, the drugs, the dyes will affect the entire kidney like tubules. So that is continuous necrosis. Whereas ischemic is patchy, like not continuous at all. Why is that? Because they all have different oxygen requirements. So, for example, this loop of Henle here will need, the red parts needs more oxygen, so they are the ones that are affected uh, for reabsorption and things like that. So the parts that do not need that much oxygen are not affected in ischemia, whereas toxic will affect everything. I hope that makes sense. So ischemic skip areas and rupture of basement membrane, in other words, tubular excess. So rupture of basically damage. So rupture of basement membrane and shedding. You see the basement membrane is damaged. Now it will cause casts. So the blue ones are the casts or accumulation. In ischemia, it would cause eosinophilic hyaline casts and pigmented granular casts. This is again specific. Why? Because uh, if you see eosinophilic, that means that this is under the ischemia, like necrosis. In cast itself, there is something called tam horsefall protein. It is a protein produced by or secreted by the ascending thick limb and the tubules, but you would see that cast, especially now, because of the damage that is happening here, okay, in the tubules. There will be some evidence of regeneration as well. Remember how I said they can regenerate as fast as well. So there will be some signs that the epithelia is coming back, like nuclei and mitotic figures in the tubules. Toxic, in the other hand, is continuous damage, including proximal convoluted tubule. Again, everything is damaged. Here, they don't need as much oxygen in ischemia. That's why it's not damaged. Some examples of toxic. Unfortunately, you have to memorize this because I had, like, there was no other way when I was also studying for this to differentiate. But basically, the toxin, so if there is a toxin mercuric chloride, the result of that, you would see large acidophilic inclusions in the cells of the tube, necrotic and everything. So mercuric, I used to remember it as uric, so acidophilic, acid, uric, right? This kind of makes sense. Carbon tetrachloride. Carbon tetrachloride will cause fatty changes followed by necrosis. So carbon and tetrachloride is fatty. Mercuric is acidophilic inclusion. The last thing is ethylene glycol. What I used to remember it was like it kind of sounds like liquid, like the alcohol. So it would cause ballooning and fluid overload, kind of. That's what I used to memorize it as. So that would cause degeneration again of the tubules. I hope that's clear. These are examples of toxin and what they can do to the tubules in terms of damage. So this is ischemia, not continuous. The casts are there, but the necrosis is not continuous. Toxic is continuous, including proximal convoluted tubule. These are again examples of acute tubular necrosis. The pictures. So you would see necrosis means like death of cells. So you would see it in the cortex, like these red patchy areas. That is signifying necrosis in gross, like in gross by the eye. In histology, you would see blocked tubules. See here, blocked, because of the shedding of the cells from the tubules, death of cells, apoptosis, and all that. They would blockage of the cells, forming casts, and in the urine itself. Now, what the last thing that you see here in this picture is recovery, signs of recovery, because they are regenerating. You would see some sort of like mitosis, some cells coming back to life, and the edge, the basement membrane forming together, forming a complete tubule cell. So all of these are signs of recovery. These are blocked cells. This is necrosis. The steps of kidney injury are three. So initiation phase at the beginning, the first 36 hours is decline in urine output with rise in the renal function test, BUN. and decreased creatinine clearance as well. Maintenance phase is maintain, right? So it's sustained decrease in urine output. So there is urine output, but it's being maintained now. It's going back into the regeneration. So it's sustaining. And the labs, yeah, the labs are still not recovering yet because of this maintenance phase. And there's overload. In the recovery phase, that is when things start to get look better. You would have hypokalemia instead of the hyperkalemia in the injury. So injury will cause hyperkalemia, but in recovery phase, because it's being overloaded with fluid in this maintenance phase, recovery phase will try to secrete or excrete all of that fluid out of the body's system. So that would increase urine volume. It's kind of like overload. So it was clogged before. Now, if you unclog it, it's gonna go the urine volume will increase because of the damage. They're trying to get rid of this overload. That will cause hypokalemia, and BUN will return back to normal because BUN was accumulating, right? So in the recovery phase, it will go back to normal because of the huge increase in urine excretion. Okay, so this is a summary from first aid. Acute tubular necrosis, I mentioned the stages. And again, it can be ischemic or nephrotoxic due to substances like contrast, ethynyl glycol, and things like that. Ischemic due to less blood flow, like hypotension and so on. Now, what is important is, okay, so you see here, this is the granular cast. If you see anywhere in the question stem, or if you see brown granular cast, that is specific for acute tubular necrosis. That is signifying the necrotic cells that came. So it's brown and granular cast. This specific for this disease. Here in the histology, it's showing you the blocked tubes. So you would see in the tubes, you would see particles or things that are getting stuck. These are the necrotic cells. What is this picture? I put this one for one of the third reason. I remember we said inflammation, any kind of inflammation can cause kidney damage. So infection, inflammation, they would not have the brown muddy, we say this muddy brown cast, they would not have that. They would have pyuria, so WBCs. So all of these inflammatory cells, WBCs, will signify that the kidney injury is due to infection or the inflammation, which was the third cause, right? Acute tubular necrosis is due to you can say the muddy brown cast is specific for it alone without infection, which is ischemia or toxic reason. Okay, the last thing, urinary casts, since I keep mentioning, they are formed in the tubules because of the accumulation. Granular muddy brown cast specific for acute tubular necrosis. Okay, see here, white blood cell, the one we just saw, white blood cell cast for interstitial nephritis. So infection, inflammation, pyelonephritis, itis, everything. So these are WBCs. The obviously red ones are RBC blood casts. They are in the first disease we talked about, glomerular nephritis. So hematuria can become red blood cells, hematuria, red blood cell cast in the urine. And yeah, that's mainly it. So this is red blood cell cast, white blood cell cast, muddy brown cast, fatty cast. Remember, if you go back to the first few slides, fats are in nephrotic syndrome. Nephrotic because they are hyperlipidemia. Fats will go into the urine, causing this sort of, it looks like flowery like lesions in the urine or casts. I call this fatty cast. The rest are not that important. Yeah, they are not specific. Hyaline cast is normal. It's non-specific finding. It's just white. You will not see that much change compared to these. Okay, so this can be found normally in exercise or anything like that. Moving on to tumors of the kidney. Yes, so kidney tumors can be benign or malignant. Benign tumors are the more common version of kidney tumors. And there are three types. So papillary adenoma, So all of these are adenoma, so benign. Angiomyolipoma, benign. Oma is benign. Oncocytoma, benign. Malignant, on the other hand, will have the most common malignant tumor is renal cell carcinoma. Carcinoma, right? So that's malignant. Transitional cell carcinoma, again malignant. Let's start with benign. Benign papillary adenoma is similar to it is similar to renal cell carcinoma. The only thing is the size. Papillary is very small, less than 1 centimeter. It is always benign, and it's most likely papillary adenoma. Angiomyolipoma, if you split the names, angio, blood, it contains blood vessels. Myo, it contains smooth muscle. It contains lipoma, fat cells. A mixture of all of these as a solid mass in the kidney, we call it angiomyolipoma, which is a benign tumor. It is most of the time bilateral and associated with a syndrome called tuberous sclerosis. So angiomyolipoma is with this neural syndrome, neuroscience. So, but it's just there for the syndrome itself. And it's pleomorphic appearance, so it's a mixture of all these 3 different types of cells, making it seem malignant, but it's actually not. It's just normal mixture of cells. Oncocytoma are from intercalated cells of the collecting ducts. The only important thing here is the chromosome, which I have mentioned in the table. So 114 and Y, something is wrong with the chromosomes that causes this mass to grow, or oncocytoma to grow. And I'll show you the differentiating feature for this. And yeah, let's move on. So these are benign examples. So if you see mixture of blood vessel, smooth muscles, and fat cells, this is angiomyolipoma. Okay. If you see this one, so I did not mention this, but if you see a scar-like tissue in the middle with necrosis, kind of necrosis with scar tissue, and then in histology you see straight, like uniform cells, it's just increased in number. Plus, this one is showing you increased mitochondria, so increased energy, increased cells, and there's this huge central scar. This is oncocytoma, the one that I didn't mention. So oncocytoma looks like that. It's benign. It's just proliferation of cells and the scar tissue. Papillary adenoma is, again, it's very small. There's no really, it's just the size that is different from this, but it looks very similar to renal cell carcinoma, which I'll show later. So this one is a mixture of normal cell and angiomyolipoma. This one with the scar and the uniform cell, these are not cancerous cells yet. This is, wait. Oh, wait, I think it's there, the name, or I'll include it, but this is oncocytoma. Okay, so this is oncocytoma. I'll add that here so I don't forget it later. Yeah. I hope that it's clear so far, that it's making sense with the division. So let's go back. So angiomyolipoma, oncocytoma. Now, let's go to the next one here. So we mentioned benign, we finished with it. What do you think this is? Let's go over the pictures first. So this is a well-rounded figure, contoured mass, solid mass. It looks like it was pressed on. I like to see that way. And here, even here, right? It's coming out of the kidney, but it's very circular. It's very like with regular borders, even though it's not like a good prognosis. In histology, you will see a lot of amount of cells present, and in another slide, you will see this kind of like dysplastic cells, you can say it, or abnormal cells. They do not look like this. This one looks more normal. It looks more uniform. This one is all over the place. It's dark cells. It has mitosis. It's not as benign as the other one. All of these pictures point towards malignant. The most common malignant cell of the tumor is renal cell carcinoma. Now, renal cell carcinoma is 80 to 90%, like if you the most common malignant cell tumor or cancer of the kidneys. It presents just like how I mentioned here. Um, so here, it's very smooth. It looks like it was pressed on, very big. And then in this part here, so these are two different types. This looks like very clear cells, whereas this looks very a lot like having projections. So this one, the clear, is called clear renal cell carcinoma from the name. This one with the projection, finger-like projection, and a very lot of like messy mitosis and dysplastic cell is papillary renal cell carcinoma. So papillary are finger-like projection. These are very, very clear renal cell carcinoma. Okay. Now, another thing that I want to mention here, the dark cells or the pinkish like structures, and I think if you zoom in, it's much clearer, but you will be able to see calcified bodies called Momo bodies. That is important in papillary. So so, Momo bodies starts with a P, it's silent. So that's for papillary. Okay. So these are all under renal cell carcinoma. It's the most common. Presentation-wise, someone will come with three main things. So they will have painless hematuria, so painless blood in the urine, right? Likewise, they will not feel that much pain in the abdomen. It will be dull pain in the abdomen with palpable mass in the abdomen. So all of this points towards renal cell carcinoma. See, often golden yellow, as you see here, it's yellow and flat. Manifests with flank pain, palpable mass, hematuria, and other symptoms which I'll get into. So if there is renal cell carcinoma, right, um, it would probably it would affect the production of erythropoietin. So losing blood in the urine, hematuria, will cause the cell to create more erythropoietin, which is a hormone in the kidney to correct the anemia, to correct the levels of hemoglobin. So that's why we call it polycythemia. That means that the kidney is trying to recompensate for the anemia by increasing erythropoietin production, so EPO. What is the, you don't need to focus that much on treatment, just focus on this. Remember the clear cell carcinoma, right? Clear cells. B is the in the gross pathology, and then in the CT finding you would see it like this. It's very hard to tell, but it's very irregular and it looks abnormal. So that would indicate cancer. It's associated with symptoms like paraneoplastic syndromes. Paraneoplastic means it increases the production of other hormones like hair mnemonic, so pyranoplastic, PTHRP. For calcium, it will increase calcium levels, ectopic erythropoietin, just like we saw, ACTH, and renin. So these are hormones that are increased because of abnormal cells in renal cell carcinoma. Clear cell is the most common type. This one is the most common type. It has a genetic mutation, so you can think that having the genetic is more common. So RCC, 3 letters, chromosome on chromosome 3, and the gene that is the mutation associated is with VHL. Okay, so VHL mutation increases the risk or predisposes to renal cell carcinoma, most commonly the clear cell type. Okay. Okay, now what do you see here? So we finished renal cell carcinoma, most common malignant tumor of the kidney. There is one more malignant tumor of the kidney that's like around 5 to 10%. It's very, very rare, but it can come with this feature. So it will come here, multiple tumors. So multiple appearance of tumor instead of one big tumor. That's one. And in histology, you would see it uh, like normal epithelium, like normal transitional epithelium that is present in the urinary like system, but very, very thick structure. So thickness is higher and multiple tumors. This is called transitional cell carcinoma of the kidney, very, very rare compared to renal cell carcinoma. So, but it arises from transitional cell. Okay, I hope that's clear, which is anyway found all over the ureter and the bladder. Multiplicity of tumors happens because of something called field effect. So let's say there was radiation to the entire kidney, it would affect all areas at once. So that's why you have multiple tumors in the same place at once. Okay, so that is mainly it for kidney tumors. We said renal cell carcinoma is the most common malignant, and transitional cell is rare, but it's something you need to know. Okay, now let's talk about bladder tumor. So we finished kidney, we'll move on to bladder. This is a bladder, it's a cut section of bladder. You see masses, very ugly looking masses here, 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 here. And in histology as well, you see very messy picture of cells. You see mitosis, you see dark cells, dark nuclei is a uh, like an indication of cancer. And here as well, you don't see a very clear cut structure. All of this is telling you that this is bladder cancer or bladder tumor. What is the most common type of bladder tumor? 95%. It is the epithelial that's making up the bladder, which is transitional epithelium. So the cancer is called transitional cell carcinoma. Very, very, the most common in bladder, but rare in the kidney. So make sure to differentiate that. So in the bladder, it's the most common. In kidney, renal cell carcinoma was the most common. So the most common type of transitional cell carcinoma is in the bladder is papillary urothelial carcinoma. Papillary means finger-like projection. Don't confuse it with the papillary in the kidney tumor. Okay, so we are now in the bladder with this one. So these are high grade, meaning very, very severe urothelial carcinoma showing anaplastic cells, abnormal cells, necrosis, pinkish necrosis areas, and high nucleus to cytoplasm ratio. That means that the cytoplasm is less, and all you can see are like nucleus, a lot of nucleus. That means it's overworking, like it's malignant and it's overproducing a lot of things. So nucleus is very dark and very big. So this is bladder tumor. Bladder tumors, again, if you want to talk about the other types, so transitional cell carcinoma, papillary urothelial carcinoma of transitional is the most common type. Very, very rare. Other types of tumors are squamous cell carcinoma. It's increased in cases of infectious cause like schistosomiasis, which is a bacteria that attaches to the bladder. This causes squamous cell carcinoma, in that case only. Adenocarcinoma, which is glandular-like, like gland structures, in the bladder is also very rare. It has specific increased risk with congenital diseases. So congenital adenocarcinoma, infection with schistosomiasis, squamous cell. So S, adenocarcinoma is congenital. So at birth, if they have defect in bladder, they will have adenocarcinoma more. Most commonly, out of everything though, is transitional. Now, symptoms of bladder tumors would be painless hematuria, and that's it. That's the most common presentation, without flank pain like the kidney one. So painless hematuria and changes in urine frequency, urgency, pain in urination. These are all symptoms of bladder tumor. Makes sense because the tumor is within the bladder. Now, mesenchymal tumors, so bladder, these are epithelial. Epithelial means the lining, like the function, the transitional, squamous, adenocarcinoma, these are epithelial. Mesenchymal tumors are tumors of the stroma, so the bladder's muscle walls or bladder supportive structure, supportive cells, if they have tumor, these are called mesenchymal tumors. Benign one is called leiomyoma. Malignant, again, oma, right? Malignant mesenchymal is called sarcoma. Sarcoma is always, most of the time, malignant. So malignant mesenchymal bladder tumor. Leiomyosarcoma, again, sarcoma is malignant, is common in adults over 40, and then there are other cancerous tumors, mesenchymal tumors in children, which is not the main focus, but I just brought it here for completion. So this way we are done with upper, like the kidney in general. We'll talk about lower urinary tract diseases now, starting from the ureter and so on. Now, I don't know why this is okay. There's two more parts. We have lower urinary tract disease and we have the reproductive part. So things like we'll see later on now, but those are the two main things that are left. So lower urinary tract, starting with the ureter. This is the normal, okay? This is the kidney, the ureter. The ureter runs all the way from here to the bladder, having three main sites of constriction or narrowing. So these are normal narrowing, but it's important to note where these are because things like stone infection can affect these three areas most commonly. The first one is ureteral junction. So between pelvis and ureter, that's the first narrowing or like narrowing of the ureter. Then crossing over the iliacs is the second. Then the third one is at the end of the thing. So vesico-ureteral, between the bladder and the ureter. That's the third one. Now, problems that can happen in the ureter, again, stones can happen. Infection, inflammation, everywhere can happen. Inflammation generally, if there is a lot of long-term inflammation, accumulation of lymphocytes, we will call it ureteritis follicularis. Long-term infection is called this. This over a long time can cause cysts. That is called ureteritis cystica, tiny cyst. So that is this one. Okay. If you see this picture, this is chronic inflammation of the ureter due to any of the things, infection, stone, and this things like that. Then there's another problem in the ureter, which I already mentioned, the stones. So obstruction, any sort of obstruction, intrinsic can be stones, can be damaged cells, necrosis. From the outside, it can be extrinsic obstruction like masses here, um, injury during any obstruction that can happen, scar tissue. Pregnancy is extrinsic, so it will push on the ureter. So obstruction and inflammation are the two main problems of the ureter. What about congenital problems in the ureter? You could have double ureter, that's congenital from birth, or you can have from birth uretero-pelvic junction obstruction. So from birth, this would be obstructed. Or yeah, it could also be here, obstruction here. This is the most common cause of hydronephrosis. So obstruction here from birth is the most common cause of dilation of the pelvis, hydronephrosis, dilation of the kidney in infants and children. So this is congenital. There is no way, nothing you can do about it. There's also things like diverticula, which is like herniation or weakening of the ureter itself, or hydroureter. Hydroureter means very big ureter that is due to nerve problems. So the nerve neuron, the ganglion is not present and it will like be slack or loosen up. The ureter will not be able to contract. It's just uh, dilated into hydroureter. So these are problems that can be done. The most important one is the one in bold, and knowing this picture is this. Okay. And the other thing is tumors. We mentioned kidney tumors, we mentioned bladder tumors. This is in between, ureter tumors. Benign, we will say benign are things like polyp and the same thing as the bladder, leiomyoma, oma, right? Oma and polyps are benign. Malignant, again, the most common malignant in the ureter is transitional cell carcinoma, same as bladder. Bladder and ureter, transitional cell carcinoma. Kidney, renal cell carcinoma is the most common. Okay. Now, what do you see here? This is the normal bladder epithelium. You have layers, you have epithelium, epithelium, lamina propria, muscular layer, and so on. In the normal bladder. Now, what do you see here that is different? You start to see septations, right? A bit weird. It's not supposed to be there. So the epithelium is going inside, kind of into the lamina propria, and it's causing nest-like structures inside. See, invagination. So This is normal. Normal urinary bladder is number one. If in any case you see this picture and it shows invagination of epithelium or urothelium into the lamina propria, causing nests called Brun's nests. So these are all epithelium in the wrong place, basically, but they are benign. So it's just invagination that can come in due to, sometimes it can be due to instruments. So some people can do surgery here, and the epithelium by mistake will be injured and it will go into the lamina propria. It can happen. But what's reassuring is that these nests are well circumscribed, so very well rounded, not irregular, so it's not cancerous, and no proliferation around the nest. So it's just nests, regular borders with no infectious inflammatory cells around it. It looks normal. So this is Brun's nest. Okay? Now we'll move on to congenital anomalies, and then we'll move on to we talked about the cancer already. You can appreciate that the cancerous ones looked very, very like all over the place, the cells. It was not at all like this. It was very like had a lot of projection, right? So that's one. This is the congenital anomalies for the bladder. So the ones that we talked about before. So these outpouchings of bladder are diverticular. Okay, diverticular are outpouching of the bladder wall. This one, where the bladder is coming out of the abdomen itself, there is defect in the abdominal anterior wall of the bladder itself. That's important to know. That is called exstrophy. So coming out, exstrophy. This one, so technically it's supposed to be a closed bladder, but sometimes in embryology, it stays open and connects with something called the urachus. Urachus is a structure that connects umbilicus to this, supposed to be closed off at birth, but sometimes it's open or patent. So it will stay open, and this is called patent urachus. Okay. Now, diverticula could be acquired due to pressure, due to urine overload, and so on. Patent urachus is another thing that is open here. Another thing similar to this, instead of patent all the way, it can close off partially and cause a cyst to form in the middle. Okay, so that is called urachal cyst. What was the problem with urachal cyst, if you remember from before the slides? It is a higher risk of cancer. So one of the causes of adenocarcinoma was congenital, right? Adenocarcinoma in the bladder, congenital anomalies. That is one of them. Urachal cyst was one of them. Let's go back and so we can see it together. Bladder, yeah, here. Adenocarcinoma increased risk with extrophy, patent urachus, and urachal cyst. So all the congenital things that we just said increases risk of adenocarcinoma, which is a rare type of cancer in the bladder. So most common cause, urachal cyst, adenocarcinoma. It looks very ugly. It's like adenoma. So adenoma is gland-like. So gland-like structures inside the cyst will predispose it to cancer, adenocarcinoma. Okay. So bladder, we mentioned congenital, we mentioned tumors. There's two more things, infection and obstruction, right? That we didn't mention. So infection can be acute or chronic. Acute cystitis or infection of the bladder, very like acute, can be a lot of things. Can be due to infection like bacteria. Asymptomatic bacteria means having bacteria in the urine without symptoms, like in pregnancy, elderly women, diabetes, because they're not able to feel the infection or respond to the infection. In pregnancy is the only case where you have to treat this condition. This is to prevent pyelonephritis and complications for the baby. Because it is two lives now, it is important to even treat, even if the patient is not symptomatic. She just has bacteria. In pregnancy, you treat it. Other causes of acute cystitis are interstitial cystitis. Interstitial means inside the bladder. Inside the bladder, there is chronic persistent infection due to an ulcer. So both of them are the same, Hunner ulcer or interstitial. It's inside the bladder, causing chronic infection. There is no infection sorry, I keep saying infection. There is no infection. It's chronic because of an ulcer, which is not treated with antibiotics. It's unknown. It's more common in SLE. That's mainly it. Sterile pyuria is talking about having white blood cells in the urine, but without infection. So we call it sterile pyuria, without infection or without nitrites, which is an indication of bacteria, like bacterial infection. So what I mean by that is it has WBCs a lot, but you could not see bacteria. Okay, you could not see bacteria. Why is that? Because the culture might be wrong. So chlamydia, tuberculosis are things that do not show up in the culture. So they are sterile pyuria. So it is infectious, but it's just not showing up in the test. And acute tubular interstitial nephritis, remember the one from before, the kidney injury that has WBC cast in the urine? But it has no bacteria in that case. Only you will see white blood cell increasing in the urine. The last thing is hemorrhagic cystitis. Hemorrhagic cystitis is this picture right here, where you see a lot of hemorrhage, a lot of bleeding in the bladder itself due to trauma, virus infection, or drugs, such as cyclophosphamide. Cyclophosphamide is the most common chemotherapy drug that can cause hemorrhagic cystitis. I think it is in the notes, if I'm not wrong. Oops. Yeah, and I put the risk factor as well. Okay, so you can review that. These are the most important again. Now, moving on to chronic cystitis. We talked about acute, most of the time infection, drugs, and things like that. Chronic, so this reminds you of the bronze nest, right? But this time there are inflammatory cells. It doesn't look as neat as the other one. There are many inflammatory cells and capillaries surrounding it. So that's one thing. So this is signifying chronic cystitis, chronic infection of the bladder. This can progress into forming, like these sort of structures that there are spaces within it. So ongoing inflammation or infection can cause a lot of edema, a lot of white blood cells to come to that area, causing edema and cystic structure. So that's why this is there. And then after that, it causes even more glandular-like structure. So in that case, we will call, let's look here. So this is Brunt nest, but with chronic cystitis on top, with the cells, right? Cystitis, cys, cysti wait, cystitis is the one where cystic structures appear. So cystitis, yeah, it's a weird name. But basically there's cysts in the coming in between. Then we have cystitis cystica glandularis, which is gland-like structures. This is this glandularis means that it starts to look more like intestine. So how do I say it? Adenocarcinoma, glandular, mainly associated with metaplasia, which is uh, abnormal differentiation of cells here. You see, it was normal before. It was okay here. It became a bit weird, like columnar instead of transitional. But here it's completely different, right? It is intestinal metaplasia with goblet cell. That's to be more specific. So it looks like the ones in the intestine. So we call it intestinal metaplasia with goblet cells. This is the glandularis. This one is just columnar cells with cyst. Okay. Now, this can progress further into this right here, which is cystitis cystica glandularis again. Okay, so my bad. This one is cystitis cystica glandularis. This is also cystitis cystica glandularis, but with the goblet cells. So this one was only columnar cells. This one is appearance of goblet cells looking like the intestinal. So it's more clear in the notes, but yeah, this one was the intestinal metaplasia with goblet cells. This one is columnar cell metaplasia only. This one is just cysts around and cuboidal cells still. So I'll go over it again right now. Chronic cystitis accumulation of cells around the Brund nests, that's chronic cystitis. Appearance of cyst plus cuboidal cells is cystitis cystica or cystitis. Cystitis cystica glandularis is appearance of columnar cells. Cystitis cystica glandularis with intestinal metaplasia shows goblet cells. It looks very much like the cells in the intestine. Um, the last thing that you will see if you zoom into the cells is something called malakoplakia. Okay, this one. Malakoplakia are basically they're and it has a certain name. It's also called Michaelis Guttman bodies, but I'm just trying to see. So they are sheets of macrophages filled with round like accumulations or uh, accumulations from the infection that stains positive with the PAS stain. Okay. Now they look um, like inclusion bodies, you can say, or Michaelis-Guttman bodies. Again, they look like giant lysosomes resulting from the infection, and they have a lot of material like surrounding it, proteinaceous, like protein-like material surrounding it due to the infection. So that can also happen. So just remember that because of the infection, there are a lot of macrophages accumulating in the area. Lots of deposits can come, proteins. These macrophages can be, filled with material, and that's what causes these cells and these bodies to form, if that makes sense. Okay. Okay. The last thing or the last problem that I wanted to talk about was obstruction. So things like stone, intrinsic, extrinsic obstruction of the bladder will cause overflow of the urine in the bladder, causing hypertrophy. So if you see these like smooth muscles increased in the bladder, that's probably because of obstruction. In male, the most common obstruction is prostate being enlarged. In female, it is the prolapse of the uterus. So the uterus so a uterus can cause something called a cyst-like structure, cystocele, due to multiple pregnancies. Females can have that. So prolapse or pushing into the bladder, it will cause obstruction. That's cyst-like structure in females. Males is the BPH or prostatic enlargement. Bladder obstruction can cause hypertrophy of the smooth muscle cells, and that can lead to hernia, diverticulosis, these trabeculations. Okay. One thing that I want to mention about this, I hope that it was clear. Basically, it's macrophage reaction to the chronic infection. Okay. And that's how it looks like. It looks like it's targeted inside there is something, and then it's surrounded by body target-like lesions. Okay, that's what I want to say. Okay, now moving on to the urethra. This is not as important, but urethra, there can be a lot of problems like inflammation, tumors, red masses. I guess the only thing from here is that it's most likely benign if there is urethra irritation. And most common cause of these painful red masses are because of the woman or the individual having low estrogen, most common in postmenopausal women. So estrogen is what keeps the urethra like not to have these masses, to be clean and painless. But because of low estrogen due to these conditions, postmenopausal, maybe even in early before menses even begins, that's when you have irritation or painful red masses because there is less protection from the estrogen. Okay. Now moving on to testis, we are almost done. We have testis to cover and prostate. I think prostate and that's generally it. That's the last thing I put for today because I tried to arrange them according to like topic wise. So we finished kidney, we finished bladder, we finished ureter, we finished the kidney injuries, and yeah, so testis, and this is the last thing. Testis pathology, and the most important things to know about testis is if someone presents suddenly with very severe pain, swollen testis, that is important. You have to rule out important like medical emergency or pathologies, and these are few examples. So swelling of the testis is the problem, right? Suddenly severe, something that looks like this, necrotic, that's almost like bluish in color and cyanose, is a medical emergency. Oops, sorry, it went. Okay, so that is a medical emergency. Yeah, that is called testicular torsion or torsion testis. Basically, this is where the spermatic cord, sometimes it can twist on itself, blocking the blood flow to the testis. So the testes are deprived of oxygen and they become blue, and it is a very, very emergency situation where it has to be treated with surgery immediately. If someone comes, mostly in young males, they come with sudden severe pain, swollen testes, what else? There is also um yeah, that's mainly it. So that is emergency to go to the OR and remove or surgically untwist the cord. Painless swelling examples can be this one right here, which is varicocele. Varicocele are painless again. They are due to dilation of veins, not the cord itself, but the spermatic cord veins that are dilating. That causes like a swelling in the scrotum right here. It feels like a bag of worms, most commonly in the left side more than the right, because the left side has a different drain. It drains directly into the renal vein. It drains into the renal vein. The right one drains directly into the inferior vena cava. So the left one is more likely uh, going to be dilated. It can be due to a lot of things. Um, it can be due to uh, just unless like it could be idiopathic, I believe, but also because the drainage sometimes can be blocked. It's shorter drainage to the renal vein. That's why. This can cause like impaired functioning of the testes, because you don't want all of the blood to accumulate here. It's going to reduce the function of the testes due to increased temperature and capillary coming here a lot. This increased temperature can also cause infertility. So it's very important to treat those as well. Another painless in infants, in congenital like this or here, which is mainly due to fluid, and if you shine a light, it's gonna trans-illuminate. So it's going to show you clear fluid inside the cavity. This is called hydrocele. It is just fluid, water retention, painless, and it trans-illuminates on the light. Congenital causes, it's because of patent. So usually it closes this part, but sometimes it remains open. The tunica vaginalis remains open, or processus vaginalis remains open. That's why the fluid comes down and it accumulates. That is due to patent opening at infancy. So this is hydrocele. It can be caused due to fluid accumulation for a lot of causes. Congenital one is due to opening of the process. Now, if someone comes with sudden severe pain, it's important to differentiate between what? Torsion, like testicular torsion, which is the picture that we showed here before, versus inflammation. They can both present the same. So sudden severe pain in the testis, right, in the scrotum. Testicular torsion, how to differentiate when someone comes to you is they will have something called, again, the cause is twisting of spermatic cord, obstruction of blood flow. They need immediate surgery. The difference between these two is if the doctor, for example, strokes the area of the scrotum, there is absent reflex. Normally, if the testis is not twisting around itself, and that the area of the scrotum is stroked by the doctor, there is something called reflex. The muscle will contract and it will pull the testis up. But because it's twisting of the cord, there will be no such reflex, and the testis will stay like fixed in its position. That's the best way to explain it. So that is how you differentiate. That's immediately you need to go to the surgery to untwist it. Versus inflammation. Inflammation will still have this reflex. It's just sudden severe pain with the reflex. Causes can be a lot of things. It can be due to infection less than 35 years of age, due to chlamydia. So these are sexually transmitted infection. More than 35 due to E. coli or Pseudomonas. These are, again, different bacteria due to age difference. Okay, so more than 35 years of age could be E. coli, Pseudomonas due to infections in the abdomen. It can go into the blood and so on. Less than 35 are the STIs, chlamydia and gonorrhea. Using instrument for testis for surgery or anything like that can introduce Staph aureus sometimes due to skin manipulation. And yeah, they will still have the reflex. However, if you elevate the testis, it is going to make the patient feel better. That is another key point. In this one, even if you lift the testis up, it is not going to reduce the pain. And they have, so no relief and absent reflex. Here they have relief upon lifting the testis up because you are reducing the inflammation and less, what do you call it? Reducing the pain and reflexes there as well. Causes can be tuberculosis, which can spread from the epididymis to the testis. Syphilis, again STI, from the testis to the epididymis. This is just a spread. Mumps is unique because it causes patchy atrophy of testis. So it doesn't cause every like the testis to be atrophied equally. It causes patchy ones. Mumps, you will also have swelling of the parotid glands in young children, and it's a viral infection. And then the other one is granulomatous autoimmune, all under inflammation. So these are non-caseating granulomas that can happen in middle-aged men. Again, it can be due to inflammation, macrophages accumulating, and it's autoimmune. There is no real reason. Now, let's move on to tumors. We said sudden severe pain, swelling, painless swelling. Tumors are an important part of this lecture because it's important to differentiate. So this is a summary. Basically, there are two types of tumors. There's germ cell tumors and there's sex cord stromal tumors. Germ cell tumors are the tumors of the cells, the germ cells that participate in spermatogenesis. And sex cord stromal cells are the things that are supporting structures, so things like Leydig cells and Sertoli cells, okay, that can go into tumor. Why? So what is the most important part of this? Risk factors of tumors are things like undescended testis, which is called cryptorchidism. So the testis not descending to its normal place will predispose that to go undergo tumor. Other risk factors are things like Klinefelter syndrome. So why is that? It's because there is an abnormality in the Y chromosome and certain genes that are affected in Klinefelter syndrome, because Klinefelter is XXY, right? So that's why the cells will be immature. They will not really be functioning from the beginning in the first place, predisposing it to tumor. Another important thing is it can cause painless firm mass of the testis, and you do not biopsy tumors at all because it will increase risk of seeding or spreading of the tumor elsewhere. So you do not want to do that. You just go straight to surgery and remove the tumor. Okay, that's mainly it. We'll now talk about the tumors in general. So germ cells tumors, there's two types of germ cell tumors, and sex cord is Leydig and Sertoli. Before that, I want to talk about cryptorchidism, so not proper descent of the testis. This is the normal seminiferous tubule. So this is the normal, how testis looks like, right? This is where the spermatogenesis takes place. It's very round, regular, normal, like producing. This one, however, looks a little bit like irregular. Everything is mixed together. There's no clear-cut structure. This one, Dr. Oban likes to call it like cookie cutter, something like this. This one, however, is not, right? And it's a mix of all the cells at once. Now, why is that important? Because this is, yeah, so I'm going to talk about cryptorchidism, how it can cause atrophic testis. If the testis is not in the normal place, it cannot undergo its normal function and it will atrophy. So atrophy means that there's reduced in the functionality, everything is hyalinized, there's thickening, no maturation or anything like that, right? Now, why do we like that's important to know the difference in histology as well as these two. So this undescent can predispose again to to tumors. Because it is in an abnormal place, it is being atrophied, it will cause abnormal cells to grow. So these abnormal cells here, this is an example. This is called intratubular germ cell neoplasia. So that is the first step towards cancer. So intratubular, inside, still inside the seminiferous tubules, but they are cancerous. They look very dysplastic with fried egg appearance, having a lot of mitosis, no maturation. Everything looks the same. No, there's no maturation like this. Important because it can be cancerous. This is the first step towards cancer. It's confined, so it's only within the tubule, but it can lead on to cancer later. This stain is called PLAP stain or placental alkaline phosphatase. It highlights the malignant cells, and as you can see here, it is highlighting all the intratubular germ cell neoplasia. Okay, so it's very important if the child comes with cryptorchidism, I can't say it, to fix or try to treat it surgically as early as possible to reduce the risk of cancer or tumors. Testicular tumors, they present with painless unilateral swelling. You have the IGC and intratubular germ cell neoplasia having either it can be differentiated into, again, germ cell, so seminoma versus non-seminoma, right? So we are now talking about only the germ cell part, so this part, this one. So germ cell can be different, can arise from this, can differentiate into seminoma or non-seminoma. Okay, that's a broader term. Non-seminoma is divided into a lot of other tumors. Seminoma, however, is the most common tumor of the testis. This is a very good summary. So we'll get to this. I'll explain it all now, but this is just for you. And seminoma and non-seminoma have different drainage. So seminoma has lymphatic drainage only. Non-seminoma tumors will go to lymph and blood. So it will be spreading everywhere. Widespread metastasis, I like to think of it as non-specific. So it will go everywhere, including blood and lymphatic. So that's a way to memorize. This one, I know the name is there. This is the most common tumor in the testis, which is seminoma. Seminoma looks very well rounded structure, yellow. It's like the renal one, but it's in the testis now. And you see a clear differentiation. If you see here, dual population of cell. That means you see normal and you see suddenly abnormal cells. So very, very well clear cut like border between the tumor and the non-tumor cells. That is seminoma. It is excellent prognosis. Why? Because it is very responsive to radiation. 90%, 100% almost responsive to radiation. Some of them will secrete a tumor marker called beta HCG, but not all of them. But that is an important marker to keep in mind. And dual population, there's no necrosis. It looks clean and well circumscribed, right? In this one as well, here, it is another example showing you the neoplastic cells. But wait, I'll actually remove this because, yeah, I think this is, maybe it's probably, I'll remove this later, so, and fix the slide. But these are the seminoma, okay? Now, this looks very much worse than the last one, right? It looks fungating mass. The cells themselves are neoplastic. They do not look uh, they do not look normal in a way. Very high nuclear to cytoplasm ratio, and so on. This itself is embryonal carcinomas. Whereas this one here, it looks okay here, but there is hemorrhage and necrosis that we didn't see before. In histology, you will see rounded structures with capillaries inside of them. This is specific for yolk sac tumors. So this one here is embryonal. If you see a mix of cells, that is embryonal. Because embryonal from the name, it's like in embryo, how everything is mixed together. There's no differentiation. Everything is mixed together. So you will have tumor markers of both beta HCG and AFP, alpha fetoprotein, younger age. It's very, very poor prognosis because it's mixed and has necrosis, hemorrhage everywhere. Here, yolk sac tumors have these specific bodies called, wait, where is it? Yeah, it's down there, but it's called, sorry, Schiller-Duval bodies. I'll move this up. So these bodies are like the cells surrounding a central capillary. These are yolk sac tumors. I like to think of it as like an egg yolk, so it makes it easier to memorize. And AFP is elevated in these tumors, whereas embryonal was both because it's mixed. Seminoma was only some of them beta HCG. I'll actually remove this because I'm not sure why it's there. I'll try to see where it belongs to. Okay. Now, this looks very, very bad, right? It's red hemorrhage and a lot of cells just expanding everywhere. That is the most aggressive form of tumor. It looks like the ones in embryo, cytotrophoblast, cytotrophoblast. So this is choriocarcinoma. It's the most aggressive, and because it is cytotrophoblast is there, it produces beta HCG. A lot of them produces beta HCG. It's small, palpable, but it's very severe and hemorrhagic. This one with it looks different. It doesn't look like these cells, but it looks like one of them is normal, one of them is not. This is teratoma. So teratoma are more than one germ layers. So having this sort of like uh, so this one actually is cartilage. So having a different germ cell like structure inside here is mature teratoma. This one is having haphazard cells. Everything is high. The nucleus is dark in color. It's very like mitotic and all that. This is immature teratoma. So if you see primitive blue cells, high nucleus ratio, immature teratoma. Teratomas just mean that there is more than one germ cell layer. So meaning like it has cartilage, it can have bone, it can have a lot of things from each germ layer, like neural cells and so on. So it can have something from the epiblast, if you remember from embryology. Okay, so it's benign in children, but it's malignant in adults. Know the difference between mature and immature. You can clearly see the difference here. Okay, last thing we'll move on into is prostate. Prostate, this is the normal histological slide of prostate. It has basement membrane. It has cuboidal and columnar cells to secrete the wait to secrete the prostatic, so the enzymes for the seminal fluid in males, right? So it also has protease to break down these seminal fluid. And yeah, like I said, it has outer columnar and inner cuboidal cells. Okay, for this. It also secretes PSA, which is prostate-specific antigen, normally. So just want to say that out because you could follow that up for tumor marker as well. Problem number one is infection. So prostatitis, acute, chronic. Problem number two we'll talk about is tumors. The second and the third one is prostatic hyperplasia. Okay, so increase in thickness of the prostate. Prostatitis, which is infection, we have acute prostatitis and chronic prostatitis, infection everywhere. This one is acute because it has pus-like structure and discharge. It's most likely acute. And it can be caused by bacteria, infection, a lot of things. There is chronic non-bacterial prostatitis, which is not due to bacteria, but it has a lot of WBCs in absence of infection. This is the majority, surprisingly, the majority of prostatitis. So people like elderly, like males, they will come and they will complain of pain in the prostate, but there will be no bacteria, and that is the most common one. It is diagnosed using survey and questionnaire. What is the most common bacteria for prostatitis? Always go with E. coli. And again, no need for biopsy of any kind because it's just an infection, or it could be due to, just inflammation in general, except granulomatous prostatitis, which is caused by BCG vaccine. So BCG is the vaccine for tuberculosis, but sometimes it's used for treatment of prostate cancer because it's shown to have benefit. This is the only time where you need biopsy because you can see the granulomatous structures and you can know the cause immediately. These are non-specific, you don't need biopsy, they are just inflammation. Now, what is this? This is the second problem. We have prostate is very large. You have the bladder there's trabeculations a lot. There's a stone in the bladder. That is due to prostatic hyperplasia. So you will see this is very nodular in shape, very enlarged compared to normal. And that actually causes backflow of urine. So that backflow is considered obstruction, causing trabecation we saw before. So remember in the males, the most common cause of obstruction was prostate hyperplasia. In histology, or BPH, benign, it is benign. So in histology, you will just see increase in stromal cells. So increase in like cells, stromal and glandular cells. So in both the functioning cells and the stromal cells, supporting cells, everything will be hyperplasia. There will be lots of projections, lots of increase in the number of cells. Due to which hormone? DHT is the responsible hormone. It's an androgen. It will increase the hyperplasia. What is the most common risk factor? Age. Age of the patient is the most common risk factor for BPH. Okay. Now, where does it take place? This enlargement, it's in something called the transitional area of the prostate. What are the symptoms? So people will come with difficulty urination, interruption of urine, hesitancy, increased, like they will go to the bathroom a lot of the time because of the backflow of urine and they're not able to urinate properly. So, but it's benign because you can still clearly see the layers, the two layers that I talked about. However, if you come here and you see again yellow, you can see a bit of hemorrhage. It's not neat and like equally enlarged as that one. It's very like it looks kind of like one-sided. And in histology itself, you can see the cells are becoming not columnar, like not cuboidal or columnar. It's losing the differentiation, so loss of maturation. That's when you suspect prostate cancer. Prostate cancer happens in the posterior lobe or the peripheral zone. So PPP, posterior peripheral zone, is the most common site of the prostate cancer, whereas the BPH was nodules all over the transitional zone in the center. Okay, this one is peripheral cancer. Again, loss of maturation, you see anaplastic cells, stratification is happening. This is precancerous. This one, same thing, but you see it glandular. So it's not columnar cuboidal anymore. You see it as glandular structures. So we will now call it adenocarcinoma. Adenocarcinoma is single layer of cells with small glands. This, on the other hand, this looks okay, right? But then if you zoom in, the cells are very neoplastic, they look weird like this one. And there is invasion, slight invasion from this high-grade prostatic neoplasia, right? So it's very high grade, and there's microinvasion, so it's very aggressive, prostate cancer. Okay, prostate cancer is very aggressive. It can metastasize to a lot of areas. Firstly, let's start with in the prostate itself. This is very poorly differentiated because there is no gland anymore, like this one. There is no more gland at all. So it's very, very poor, severe cancer, no glandular structures. And when you see the cells becoming single, that's actually really bad. So this, we call it Indian filing, or single cells lining with no glands. That is the most severe form of prostate cancer. Now, in staining, this one is immunohistochemistry. Remember, PSA is normally produced. So if you stain it, it's gonna have increased PSA everywhere because of the cancerous lesion. This is invasion into the neural space, so neural nerves. So nerves, perineural space, this is the nerve, and there's invasion, prostate cells all over, small, 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 all over here. That is invasion into nerves. Then we have the most common, sometimes a lot of elderly will come with back pain, and you should rule out prostate cancer, because prostate cancer can actually metastasize to the back, causing osteoblastic lesions and back pain. Osteoblastic means forming bone lesions. Okay, so it's very hard, but it makes the bone very weak and predisposed to fractures, pathological fractures. Screening tests. So how do you screen for prostate cancer? In digital rectal exam, when you examine the prostate, you will feel firm nodule, very specific nodule in the prostate. Okay. Whereas in BPH, it will be very rubbery, like, and diffuse enlargement. This one, only one side will be enlarged in DRE. Be careful of the levels of PSA. That's important. So PSA is prostate-specific antigen produced by this. If it's more than 4, if it's less than 4, it's most likely benign. If it's more than 4, abnormal. If it's more than 10, it's very highly suspicious of cancer. So between 4 and 10, it's like a gray zone. It could be cancer, it could be other things like prostatitis, BPH, everything. All of these can cause high PSA between 4 and 10. Now, the prostatic intraepithelial neoplasia, the one that was only limited without the microinvasion, only limited to the prostate without invasion, do not increase the PSA value. Keep that in mind. And yeah, so what is important, because it's a very gray zone, you need to look at the ratio of free PSA to total PSA, because in cancer, most of them will be bound, most of the PSA will be bound to protein-like structures in cancer. So free PSA will be low. If the ratio is lower than 25%, most likely cancer instead of the other reasons. Okay, because it's most likely bound in cancer. Velocity of this increase. So if you screen someone over a year and their PSA increases rapid velocity, like more than 0.9%, let's say more than 0.9 scoring in here. So for example, this year it was 4, next year it was 4.9, the other year it was more 5.8, something like that. That is very suspicious of cancer. So if it's increasing slowly, that's fine. It might be due to BPH, but if it's increasing fast velocity, it's due to cancer, most likely. And sliding scale. Sliding scale means adjusting the PSA level for age. So if someone is 60 and someone is 30, you would just try to adjust the PSA level you see according to their normal age groups, because sometimes it can be more than 4, but it's normal in younger adults, right? Now, in older adults, because with age it increases. So acid phosphate, this one is another marker. So this is for PSA. And this one is other markers. So acid phosphatase will be positive when it spreads outside of the capsule, and alkaline phosphatase will be positive when it's already in the bone. Okay, so keep that in mind. So these three, I'll write it here. This is talking about PSA levels. Okay, because I didn't mention that. So these three are the markers for prostate cancer and metastasis, and to know if it's suspicious of cancer or not. Let's do questions. We're done with the review, but I hope it helped. It was a very, very quick revision, just the important points. So let's do some questions. And because this is a recording, feel free to pause. I'll go ahead with the answer once I finish reading it. So 58-year-old man, stable condition after myocardial infarction. 2 days later, his urine output decreases and serum urea nitrogen level increases to 3.3. That's the BUN. Oliguria persists for 5 days, followed by polyuria for 2 days. So decreased and then increased. He is discharged from the hospital. Which of the following explains these renal abnormalities? So you have increase in BUN, which is a renal function test. There was less urine first because of the myocardial infarction and hypotension. Then it increased due to regeneration. So that's what we call injury, acute kidney injury or acute tubular necrosis. Another specific, what's the specific cast that you would see in acute tubular necrosis? Is the muddy brown cast. What is the cause of this acute tubular necrosis now? It's because of ischemia, not toxicity. So ischemic kidney injury because of hypotension. I hope that was clear. 7-year-old boy is recovering from impetigo, which is infection. Physical exam shows 5 honey-colored crust on his face. The crusts are removed. Culture shows Streptococcus pyogenes. He is treated with antibiotics. 1 week later, he develops malaise with nausea, slight fever, and dark brown urine. Serum anti-streptolizin O titer is very, very high, which is specific for strep throat. Which of the following is the most likely outcome of his renal disease? So if you want me to answer, this one is 1 week later after infection, is post-infectious glomerulonephritis. We said that it resolves spontaneously with supportive treatment. So complete recovery. Okay. 44-year-old man with increasing malaise for the past month is bothered by increasing swelling in the hands and legs. There is generalized edema. He is afebrile. His blood pressure is high. Urine analysis shows pH of 6.5. The values will be given. So 4 plus proteinuria, no blood, no glucose. Microscopic exam shows no cast or RBCs and 2 WBCs. 24-hour urine protein is 4.2 gram, which is more than 3.5. Renal biopsy shows immunofluorescence staining to C3 component, complement of in this granular pattern. Which of the following underlying disease process is most likely present in this man? So this makes you think of nephrotic syndrome, right? Nephrotic syndrome. Nephrotic syndrome, one of the most common with deposits and nephrotic syndrome is membranous nephropathy. Which one of the following is a very common risk of membranous nephropathy? This is one of the reasons why I didn't mention it in earlier. It's because of chronic hepatitis B. HIV was for FSGS, focal, right? Multiple myeloma was for amyloidosis, remember? And yeah, that's it. This nephrolithiasis means stone. HIV was for FSGS, remember that. Heroin and things like that. Hepatitis was for this membranous nephropathy, which I mentioned it now, but not in the previous. What is your diagnosis based on these pictures? This one is showing, it's all in the notes, pink nodular structures, so Kimmel-Wilson nodules for diabetic nephropathy, specific. This one, this patient presents with hematuria on and off, but it's not painful. And he has dull pain in his abdomen with palpable mass. He has anemia. He has, yeah, this is, what is it? It looks yellow. It's like in the kidney, distorting the shape, but still well shaped. It's renal cell carcinoma, most common type of cancer in kidney. This one is presents with sudden severe swelling in the scrotum, absent reflex, absent elevation of pain, very sudden, very severe after exercise, let's say, testicular torsion, medical emergency. This one is a testicular tumor that was taken with showing the structure. What is this? This is yolk sac tumor. Okay, yolk sac is the one with the shivel duval. I can't say it, but shivel duval bodies, which is the one that looks like the yolk with the capillary inside. Question: 61-year-old woman has experienced increasing bouts of abdominal pain for past 5 years. She has blood pressure is very high. On auscultation, she has click over the mitral area. Bilateral abdominal masses are palpable. Abdominal ultrasound shows enlarged kidneys with this figure. Which of the following condition is she most likely to have? So this is not cancer, right? Because it's bilateral, mainly cystic, and increased blood pressure. This is most likely in adult in 60, presenting very late, is adult polycystic kidney disease, autosomal dominant polycystic kidney disease, most likely associated with berry aneurysm and liver cysts, extra-renal condition. Okay. Oh, I'm so sorry. I don't know why it's there. Okay. Okay, so what is the members of a family with renal cancer undergo ultrasound screening? 2 adults found to have bilateral renal mass lesion, multifocal bilateral. Biopsies are obtained. They show a papillary pattern. So this is renal cell carcinoma, most likely the papillary type, the one with projection. Mutation involving which of the following genes is most likely found? I didn't mention it because this is an important point, but papillary renal cell carcinoma is associated with MET mutation. Okay, and I have that written. PKD1 is for polycystic kidney disease. RAS is not related. Tuberculosis, Wilms tumor is not related. I'll show it to you now. A 65-year-old man recently retired after many years in a job involved exposure to aniline dyes, including naphthylamine. 1 month ago, he had episode of hematuria that was not accompanied by abdominal pain. No abnormal findings. Urine analysis shows 4+ hematuria, so blood without anything, shows RBCs. Microscopic exam shows RBCs, 5 to 10 WBCs, no crystal, no cast. The result of urine culture is negative, so not infection. Cystoscopy is performed and biopsy is obtained. Which of the following neoplasm is he most likely to have? Now, number one, this looks like cancer. It's been for many years, and he has painless hematuria. Painless hematuria can come with urine, bladder cancer, or renal cell cancer, kidney cancer, right, in the kidneys. But he has no abdominal pain, and the risk aniline dyes is reported for more bladder cancer. Remember, it can be caused by dyes. And this does not look like it's in the kidneys, so it looks more like the transitional epithelium of the bladder. Remember the umbrella dome shaped? So all of this points us towards not urothelium, bladder cancer more than kidney cancer, right? So bladder cancer. What's the most common type of bladder cancer is transitional cell carcinoma, or in other words, they will say urothelial carcinoma. That's on the other name for transitional cell carcinoma. Okay, 29-year-old man complains of vague feeling of painless heaviness in the scrotum. He is healthy. The testis is slightly larger than the left testis, the right side. Ultrasound shows solid circumscribed 1.5 centimeter mass in the body of the right testis. Representative gross appearance is shown here. It looks well circumscribed, right? And yellow. A biopsy is done, which you shouldn't really do biopsy, but yeah, that's an important point. Do not biopsy if you suspect tumor. It shows uniformness of cells with distinct cell borders. glycogen-rich protein, and round nuclei with prominent nucleoli, which is feature of malignancy. There are aggregates of lymphocytes between the nests of cells. Which of the following features is most characteristic of this lesion? You can go ahead and read it. I would answer, so the most common, so this is in the testes. So you're thinking of testicular cancer because of tumor, because of all of these features. It's a very big mass, and it's painless. Now, what is the most common cancer or tumor in the testis? It's a germ cell. Which one? Seminoma. Seminoma is the most common one. Now, what is characteristic feature of seminoma? Not syndrome related, not pulmonary metastasis. We said HCG in certain people, but not everyone. But what is more certain is that it has a very good prognosis and complete response to radiation therapy. So that is the answer. Okay. 45-year-old man comes to the physician for routine health maintenance examination. Physical exam, there are no findings, but yeah, creatinine is 1.1, which looks normal. Urea is okay. Alkaline phosphatase is a bit high, 89. Prostate specific antigen is more than 10, 60. Prostate biopsies are performed and high power microscopic appearance is shown. Which of the following is the most likely risk factor for his disease? This is also one that I did not mention, but it's important. You're thinking of what? If you think that that's more than enough for me, this is prostate cancer, right? Because we have high, more than 10, you're suspecting it is glandular, like it's not, does not look like the normal two-layered cell of the prostate, two-layered cells. The most important epigenetic, not epigenetic, mutation for primary prostate tumor or cancer is hypermethylation PSTP1 gene. It was bolded, and the most important part of Dr. Oban's lecture, it was written very clearly. Exposure to other compounds, no. Overproduction of androgen, no. That does not signify, it increases the risk, but not for cancer. Smoking is not a risk factor as much as epigenetics, and UTI is not, right? So that is the most important. These are the most important genes for each disease that was mentioned. So we have, I wrote the gene and the location. Hopefully it helps. And you will see the things that were mentioned in the lecture that is important. So things such as, I mentioned all of these in the lecture now. Prostate cancer can be hereditary, acquired somatic, or epigenetic. Hereditary means family, right? And based in African Americans, this is the MYC gene. And you don't need to know the location, but MYC gene is important. In white Americans, it's a certain locus that is in chromosome 1. Prostate cancer that is acquired somatic, so someone who does not have family cancer, acquired somatic would be androgen promoters, a fusion gene located in chromosome 21. So TMPRSS-ETS, which is it's an androgen receptor that is responding very, very much more response to androgen, which causes the cancer. Prostate cancer epigenetic mechanism. This is the most 90 to 95%, the most common for primary prostate cancers is hypermethylation of GSTP1, which is glutathione S transferase, which is the one in the MCQ. This one is acquired somatic, but less common than this. Okay, so just be careful of that. These are important, very important, which I saw from the lecture. Testicular cancer, as I mentioned before, the Y chromosome having in Klinefelter syndrome especially. Hereditary clear cell cancer was VHL, right? Papillary was FMET, the one in the MCQ, FMET. This one was in the summary for renal cell carcinoma. So I'll write here, renal cell carcinoma, hereditary renal papillary carcinoma. This was on chromosome. Okay. So 3-letter 3 and RCC 3. This one, the MET is papillary, just like in the MCQ. Thank you so much for listening. I hope it helped. I hope it was able to cover a lot of the topics at once. I'm sorry if it was a lot, but hopefully it's a good revision. And yeah, please fill this QR code out for feedback. And let me know if you have any questions. You can reach out to me anytime. And best of luck in your exams. Thank you.